Good afternoon, everyone. What an important audience is here. So many people working with such dedication. I am pleased to open the session as chair, and we are with a lecture by Dr. Tali Sahar. So, Dr. Tali Sahar is a specialist in family medicine and pain management. She heads the pelvic pain department in the pain unit at Hadassah. She manages the pain management area for Clalet Health Services, Jerusalem District. Thank you, Tali. I will speak with you briefly and about a significant change, a shift in perspective that many of us women are trying to achieve. And the good women here are working to create in the field of pain during sexual relations. Essentially, we can see that over time, the approach to pain during sexual relations has appeared. If you look at my screen, you can see. Wait. You can see. So, the approach to pain during sexual relations was like that, generally. The concept of pain wasn't specifically addressed. There was something we call a dichotomy. The separation was an anatomical approach to the location of pain, whether was it more superficial or deeper? Or an approach that said, I examined and saw that there was nothing superficial or deep or anatomical. So what did they say to people? Well, there is. You have something psychological. And essentially, we see over a long period of decades of literature on pain during sexual relations, a sort of division like that. Either we address the organ or the deep tissue, or superficial, or we address it by referring to an emotional treatment. We propose something that was also published in a newspaper. It's very important in the world of medicine and pain, treating sexual pain as a pain syndrome. And regarding pain, there has been a very significant revolution. It came after others. A component upon it, which essentially means that as more and more information is added to our knowledge, they began to formulate. And they mentioned it in today's first lecture, or the fifth, but really at the beginning of the day it was, such as the World Pain Organization, decided to formulate 3 mechanisms of pain. They also suggest treating pain with a mechanistic approach. What is the mechanism that creates the pain, and what are these 3? So let's go over them. One type of pain we see is called nociceptive pain. This pain originates from the tissue itself, and we will expand on something you are familiar with like inflammation or infection. It is usually warm, or you will feel something clear in that area that is visible. And it is usually almost always a sharp pain that warns of something. Chronic ongoing pains. The second type is about the wiring, which transmits information from a specific area to the brain. It is called nerve pain or neuropathy. In a moment, we will see more pictures of it. And the third and newest type is some pain related to pain processing in the brain. And in the past, it might have been called psychological. But today our understanding regarding the ability to heal and the comprehension when it comes to a complete pain processing mechanism is different. It is different. Now, what used to happen many times, and they will also talk about this later, that people would tell me, usually women, they would say that as we discussed, there is such an emphasis on pain in men. Look, we did this and this then. Don't you have something? Come address it mentally. Today we know how to identify. And even if it's talked about later, how can we get clues that the pain is nosoplastic? And for nosoplastic or plastic pain we have excellent treatment methods. I want to bring this now, really, in pictures that were published by the International Pain Association in one of the most important newspapers in medicine. They are trying to explain what these mechanisms are. So nociceptive pain is natural. I told you, it will usually be in something acute. A heart attack, a kidney stone, an ulcer. Something that is happening to me now, and the tissue itself is warning of the pain. The neurological aspect is somewhere in the nervous system. It's located from the tiniest nerves all the way to the brain. The pain, as we understand it, is in the processing mechanism in the brain. So, if we look at this together, let's do a small test for ourselves. It will be most effective in the tissue in the area that currently has a burn and damage. Pain neuropathy, where will it be? Wherever along the path and the routes that rise from the tissues to the brain. And pain nosoplastic, we like to call it, will be in all the processing that occurs in the brain. It will be comprised of a great deal of learning that the brain has done throughout life. We have brought a slide here. You will learn a little more about this shortly from Dr. Efrat Surakwi, which is basically in the last 15 years, even 20, our ability to see brain function in MRI has improved. Many learning pathways have been revealed. Pain in the brain, pain prediction. You will hear more about this soon. And essentially, these pathways were created. A small example. Do these lines look equal in length to you? They appear to me. If they are equal, not only are they equal, but they are precisely measured as equal. I copied the line in PowerPoint. Do they now look equal in length to us? I hope they don't look equal in length to anyone. Our clever brain creates an illusion. Optically, it helps us perceive dimension, but it creates the illusion. We can sometimes perceive things differently. This happens because of it. Brain processing. The same brain processing. Now we are given additional information. Now we see the lines differently. And essentially, if we want to go over all of this brain processing, it can sometimes be so clever. And it sounds like it can also be connected to insights regarding damages. Also to insights regarding security. And we can, with these simple tools, understand these things and understand that something can be created in the brain. Some kind of generalization to help with healing. So how do we do it? Through questioning. Through physical examination, through accompanying tests. This gives us clues. As people who view the problem as a pain problem and not as an anatomical problem or a psychological problem, this gives us clues for classifying the pain. Classifying the pain, we begin to understand what kinds of pains are present. This kind of pain, and also this one can be found. Listen for a moment. And according to the pain classification, we also consider how this pain will affect me. That is to say, it goes beyond what types of pains caused me this. Did they prevent me from moving? Did they cause me to avoid relationships? I am intentionally speaking about general pain here, because that is the approach to treating pain. And then I build a multidisciplinary treatment plan. It is tailored to my different types of pain. And you will hear about the issues afterward in medicine. When it comes to pain, we have many tools to treat it. There are also many tools that work through the brain. You can call them psychodissection, brain psychology. It is very helpful in pain management. For healing, we have physiological tools. Physical therapists, movement things. We also have medications for things you may have heard of. We have procedures. And But we do it all according to the classification of the pain. And at this point I am passing the baton to you. After we know how to build a treatment plan and how to integrate it into the circle of magic, we will move on to discuss how it actually relates to the pain disorder of pains in sexual relations. Thank you. Thank you, Tali. Thank you. I will continue with you. You are exactly my words. Because. So it's very nice. I am Dr. Efrat Sarakwi. I am a specialist in rehabilitation medicine for several years. I led rehabilitation and recovery programs at Hadassah. And now I have founded the first center of its kind in the country, multidisciplinary, the first in the country that deals with research, training and multidisciplinary treatments for nosoplastic pain syndromes. Among them are also pain related to sexual relations. So we will continue what Dr. Sahar spoke about. And we will talk specifically about nosoplastic pain, and what we will try to touch on briefly today. The main points will be given a definition of the term nosoplastic pain later. We will talk a little about what was mentioned earlier regarding the mechanism of the central nervous system. We will discuss several syndromes that exist in the world. Content referred to as a neuropain syndrome. Nosoplastic relates to pains associated with sexual relations. How does this affect questioning? What are the things I, as a therapist, would want to ask? Or the things I, as a patient, would want to say that are significant during a physical examination? And principles of treatment. And let's say a word at the end about the campus. So, our starting point today in pain medicine is that essentially all pain is created along the central nervous system. And the understanding is that our body tissues do not have pain sensors. They have damage sensors. This is a shift in perception that gives us a basis to move from the location of the pain, essentially, to its mechanism of formation, as I absorbed it earlier. And the important understanding for all of us is that pain is not a measure of damage, but rather a measure of the level of threat. And we will soon discuss what that means in terms of the pain mechanism. It is what determines the clarification process and the treatment process. So, what is the significance within the three types of pain? Neuroplastic pain is pain that stems from increased activity of the pain network in the central nervous system. Along the spinal cord and within the pain network, it is not one area in the nervous system without tissue damage, or where there is tissue damage. However, the pain and the intensity of the pain are far greater than the damage itself. I will say that beyond that, as Tali mentioned, pain syndrome is not just localized. Precisely because it is systemic, it has effects on many systems. And not just on pain. So what does that mean? The pain network and what it is composed of is made up of several key aspects. One is our areas of perception. The frontal areas of the brain, the prefrontal areas of our perception. Perception of danger, perception of threat. The second area is areas of sensory processing. Information arriving from different sensations in the body, not just receptors, but also damage sensors that provide information when there is tissue damage. These pass through the spinal column and arrive at areas of brain processing. The third most significant within this network is our emotional system. It is also connected to the processing of emotions and threats, but also to understanding a threat versus security in general. Within our life systems, this network communicates closely with our autonomic nervous system, which is located in posterior areas of the brainstem, and is connected to the pulse, digestion and breathing, to blood pressure, posture and reaction, the muscles, and therefore we often see these kinds of symptoms. They will be accompanying, for example, in situations of pain attacks, also during sexual intercourse, but generally, there is increasing knowledge today regarding the meaning of increased activity within the central nervous system. However, we know that there are areas where there is excessive stimulation of the system, compared to places where there is a suppression of activity. This is a suppression that we would want to occur. A suppression of information regarding a threat is intended to prevent any threat from causing severe pain. but there is damage to the suppressing areas. We know that there is stimulation, and the writing here refers to glial cells and cells connected to the immune system within the central nervous system. There is a change in perception and in networks between different areas of the brain. And there is also connection and activation of the autonomic nervous system. Sometimes this can be a delay, and sometimes it can be overstimulation. So, how does nasoplastic pain develop at all? Nasoplastic pain generally develops in two ways. It can develop in accordance with something. It means through some kind of damage to the tissue in one way or another. And information that arrives, as Tali described, from the area of the tissues to the central nervous system. For example, a traumatic birth, very difficult. Or a tear that takes time to heal. Or procedures of this nature. Any such event, if there was extensive learning by the brain regarding the damage that occurred, especially if it was repetitive, or for example, some inflammatory damage of this kind or another in the tissue, the more repeated information there is about damage from the body to the brain, the brain will increase its activity. There is a chance many times that even after the damage is peripheral, or the damage in the periphery, the central nervous system will continue to function at a high level. Even though the damage has already subsided and been treated, this is the way. One option is top-down. That is, the nervous system itself responds to various threats it has experienced, and essentially creates pain in the periphery without any damage in the periphery at all, without any damage to the body's tissues. This can be a threat of fear. This can be a threat of perception. This can be a threat of a traumatic experience. It is primarily related to our perceptual systems. It is important to say, for example, neuropathic pain. It is always a physiological experience. It is not a voluntary mechanism. I often hear from patients who are also told that if the pain is in the head, then the pain is not in the brain. It is in the central nervous system. But no less important than that is the fact that it is not a system I control very often. Sometimes people, and women in particular, feel guilt because of pain management companies. It is something very important to understand within the learning process. None of us can intentionally create pain the way we move our skeletal muscular system. The third important thing to understand is that, physiologically, the nervous system has logic. Sometimes it is logic that is very clear to us, like moving away from someone who threatens me. But sometimes it is logic that is not at all within my conscious awareness. The most important thing about pain is nasoplasticity. In the vast majority of cases, even when dealing with very severe pain syndromes, they are reversible in the vast majority of cases. And even completely reversible. And that is an important revolution in pain medicine. So, what symptoms can we see that indicate the central nervous system is activating its threat network? As we said, it's a network. And it activates and connects to many physiological systems that exist. And what specifically do we see in pain during sexual intercourse? So, the muscular system's response is often a system of contraction toward what we call, in rehabilitation medicine, a contraction of the psoas muscle. Without the ability of tone, of relaxation and contraction, as we would expect from a skeletal muscle. Not in a state of threat. We can see situations of allodynia, meaning very heightened sensitivity to touch. And also, for example, even after there has been contact or, for example, sexual relations. With sexual relations over, the pain can continue even though there is no longer contact. There is a delay effect with the tissue from the nervous system, and the pain can persist for minutes, hours, or even days. There can be local symptoms of itching or a burning sensation. And essentially a kind of improper loss. From the periphery, the brain can project to additional areas. The system does not respond as it should to the damage. Therefore, essentially, there is a lack of accuracy in the understanding of the message from the body to the brain. And there can be projection to the legs, many times to the hips, can be to the lower back. There can be projection to the rectum area. For example, pain during bowel movements. Then projection to the central abdomen. And sometimes even to the upper abdomen. There can be a sensation of stabbing pains. Sometimes during severe pain episodes, autonomic symptoms such as a rapid heartbeat can occur. A feeling of blood draining away. A sense of discomfort, nausea, heartburn, urgency and urination, and essentially a connection to other systems that interact with the pain network. What is important for us when we want to ask what is important within the diagnostic process? Because the diagnosis needs to be guided. So, we definitely want to see how the system is responding. Is there damage? Is the brain responding to some peripheral damage of different types? And therefore, the diagnostic process is so important. But as Tali mentioned, this isn't a diagnosis for which we have additional criteria we want to check to play a role in what further supports the idea that this is neuropathic pain. The examination is important in this context, because previously our focus was mainly on tissue and locating the source of the pain in some way. The assumption was that the more pain I feel, the higher the damage must be. Today we understand that we want to assess pain. We need to assess it at a systemic level, from the tissue level through the spinal cord to the brain, an assessment of the entire network through its sensory, perceptual and emotional areas, and to understand the patterns of response to touch, pain, stimulation, and so on. The principles of nosoplastic pain treatment have 5 key principles. As we mentioned, diagnosing the pain mechanism is what should guide the treatment. Within this process, of course, there is a differential diagnosis at the moment, so that we know and the mechanism is clear. We want to provide knowledge. I do address pain. I want to understand exactly what is happening to me in the tissue, how my pain system works. How can it be that this is such strong pain with seemingly something very minimal in the tissue, if at all, or even more? Why do others feel less pain and why do I feel so much? There are a lot of questions to address and organize at this stage. Third, we want to reduce doubts. The goal is to strengthen your understanding of the diagnosis. This will help reduce the fear. Fear is a very strong factor in pain, and certainly in intimacy and pain during sexual relations. This will allow a gradual return to touch and activity. Subsequently, sometimes we may see connections to emotional threats. These are related to activating the brain's pain mechanism. Therefore, as we work holistically, our goal will be to work on the entire pain network. And we do not break it down into parts. I will say a word about our work on campus. As someone who sees many women dealing with pain syndromes in general, and pain during sexual relations. So one thing I see is women coming in with a diagnosis of pain during sexual relations. But I see a great many women for whom that is not their initial complaint. They come in with other syndromes. But when we delve deeper, we see that this too presents a difficulty, and a difficulty with touch, and very high arousal. It is important to understand in this context that when there is a nosoplastic pain syndrome, when the nervous system is in a state of high arousal, it affects my entire experience in space. Certainly when it comes to an intimate experience, the only thing I want to take you to is the experience that patients describe within. And there is logic behind the central nervous system. There is a great deal of emphasis on understanding. The feeling of coherence provides a great deal of confidence, and it's a very significant factor in the journey. When there's a feeling of connection to myself, there is much less need to please others. There is much more attention to the path, and to the pace I need in order to heal, self-tools and a great deal of independence in the process. I thank you. We will move on to the next speaker. So I am glad you will continue. Dr. Orna Reichman. Orna is a gynecologist and manages the Benign Vaginal Disease Clinic. She also manages the Obstetrics Ward A for labor and delivery. At the Shari Zedek Medical Center. Now you can hear me and her. The presentation isn't displaying correctly. Can you see the presentation? One moment. Can you see it now? Didn't you do it through share? Interesting. One moment. Also the middle, me, is 2 considered another something? Excellent, now that costs, but only if there is a minister. Not of the screen but of your presentation. Great, that's it. Can you all see? Yes, it came up. You can see, thank you. So I'll try to take us to the level of what Tali and Efrat presented. And we will proceed. Regarding a patient who comes to the clinic with pain during intercourse. And how to adopt the method of thinking about leading pain mechanisms to a diagnosis of plastic pain. How? By explaining it to her and reflecting the diagnosis back to her, of course. That is. The issue is always much more complex. The presentation is a little more simplified, but it's essentially to convey the message. So a woman is sitting in front of me. I need to help her and diagnose an issue of pain in intercourse. So I think the first sentence I always tell her is that her pain is real. She is not imagining it. She comes after a lot of frustration, a hinome. She shared with us this morning that women came to her after being advised to drink a glass of wine. So first of all, to reassure her that the pain is certainly real, and it is physiological pain. The second thing I am very careful to say even before we delve into the pain is, there is a mechanism just like with Tali. She explained it to us, and my goal in this examination will be to understand what the pain mechanism is. And sometimes it's complex because it's several mechanisms together. But for almost every mechanism we have a good and quality treatment arsenal today. And pain is not a decree from heaven. And for most patients we manage to help. That's how I begin, and then like Tali told us, I tell the patient experiencing pain there is a mechanism. And before I examine you, I want to share with you what I will be looking for. First, I will be looking to see if there is any tissue damage. So here we have a picture of a hand. We are, of course, talking about the Italy garden. I am telling her I will see if you have inflammation in your vagina. Do you have an inflammatory infection process like a fungus like thrush or something from an assault like group strep? I won't give you the whole list. Do you have any damage to the tissue of the vulva, scratches on the skin? Therefore, sclerosing contact dermatitis, various skin diseases. Do you have pain due to stretching? Are they as prepared by the secretary this morning? Every stretch of tissue has stretch receptors. I am going to use a microscope. I am going to use pH paper. We will send cultures as needed. That is to say, the goal is to share this with you. Your line of thinking is based on a mechanism of tissue damage. And what about that? Additionally, I sometimes say that we don't always see tissue damage. But still, after childbirth there is scarring. And it's possible that there is nerve tissue trapped within the scar. Or nerve tissue that has been damaged. Classically, damaged nerves are diseased. They scream, burn, and ache. I actually stopped talking. I'm going to check on her before all the questioning begins. I see that she has a legal cost. That's what we talked about today. Gentle contact that shouldn't hurt, which is interpreted as strong pain. And pelvic floor contraction. Now sometimes they only say sometimes. Just pelvic floor contraction. Many times they say both things together. And at this stage I've already decided in my mind that she has neuropathic pain. It's true that not every burning sensation upon entering the vagina or vestibule is due to neuropathic pain. And not every pelvic floor muscle contraction is due to neuropathic pain. But I'll soon explain to you why I reached the conclusion that this is the diagnosis. Now I am sitting with the patient who was always told it's in her head. And she was sent for emotional treatments. And I believe her pain mechanism originates in the brain. And I need to reflect that to her. So when I started and spoke with her about pain mechanisms, I explained to her that there is a mechanism based on tissue damage. And there is a mechanism based on nerve damage. I haven't fully introduced the third mechanism yet. And then we sit and talk. And I tell her, look, I examined you. And we know that the cultures have already been sent. And we sent a PCR test. And there is no damage to your tissue. And also, there's no issue of scarring or nerve damage. So you are actually experiencing real pain. It's burning you, it's searing you, it hurts you. But it's happening against a different mechanism. And then I start to explain to you what that mechanism is. And I tell you, let's put the pain aside for now. Let's see how our brain knows how to influence the periphery. For various reasons. And there are things you can really connect with. For example, when we get excited, we can feel sensations in our stomach. When we are embarrassed, we can blush many times. They added intuitive examples. She tells me yes. When I am stressed, I vomit. That means it is easy for her to connect with the idea that the brain isn't really about pain. It knows how to create an effect on the periphery. It is clear to us that it is actually operating this entire system of our body. But if, for patients, this doesn't exist. So, let's give examples of how the brain influences other mechanisms in the body. And then say, in the same way that I often say there is a road. It's two-way. That is to say, you can get from Jerusalem to Tel Aviv. You can also get from Tel Aviv to Jerusalem. That is to say, the periphery can give information to the brain. But it costs the brain. It can also activate things and give information to the periphery. And then the question is, how does it do this? You are not imagining it. And then I say what Efrat said earlier. She showed us the brain knows how to contract a muscle. I don't think any of us has ever had a muscle cramp. It's excruciating pain. And the brain also knows how to lower nerve sensitivity. This phenomenon, which we gynecologists experienced, surprised us. We never knew how to explain it. It exists in many people with chronic pain who are fair-haired. The pain appears in the knee, shoulder, back, and face. That is to say, it's a very well-known phenomenon, and it is associated with it. With chronic pain, and I believe this is more or less the mechanism. Why does the brain do this? That is already very complex. There are many reasons, and certainly not in 10 minutes for me to discuss. But there are truly various and diverse reasons why the brain does this. To understand that the mechanism is physiological, it is not emotional. There could be a trigger of stress or some other trigger. But the mechanism is real. And therefore, when it needs to be treated, it is pliable. So, the treatment mechanism consists of several aspects. If the muscle is contracted, then physiotherapy, pelvic floor exercises will treat the muscle. If the nerve has a high sensitivity level, any touch causes a burning sensation, then the nerve will also be treated. It can help. But if we don't address the original source of the thinking that creates it, the mind that creates it, we won't solve the problem. Therefore, the treatment is concurrent. That is to say, on one hand, alleviating the symptoms, pain created by the mind. And on the other hand, the basic treatment for pain is palliative. This is pain education. It's about understanding the pain mechanism, and about acquiring tools and practices to influence the brain, and to stop doing it and how, with awareness, it does it and to control it. And to reduce the frequency of these events. And as Tali, I had the great privilege of working with Tali as well. And with Tali Sahar too. And we really managed to bring this understanding of mechanisms. Is the mechanism additionally effective? Damage to tissue? Is it neuropathy? Or is it nasoplastic? And we decided to place vaginismus and vulvodynia in the archive under a syndrome that is nasoplastic. Many doctors will come here, and they will say, well, you can't weaken it because you have pelvic floor denervation or contraction. The plastic issue, we can see it here. Where's the pointer? We can see the overlap here. Dynia could be from fungus, and on dynia it could be from nerve damage, and on dynia it could be from muscle contraction. How do we actually make the diagnosis? So, to make a diagnosis of plastic pain, it's not just the expression in the tissue that the muscle is contracted. Or there are things on dynia which are very well-known characteristics of pain. It is plastic. Rather, we are looking for other characteristics. So, here is a list of characteristics. We don't need all of them. But we do need other things. We've already addressed the fact that we have no tissue damage. It does the job very well. The pain intensifies only around emotional events. I'll bring some examples from the clinic shortly. Specifically, it appears. Specifically, it doesn't appear only when thinking about the pain. It doesn't appear only when thinking about the action either. The pain is created. We recognize this from many gynecological examinations. We haven't examined the patient yet, and she is already tensing up and experiencing pain, so there is certainly another component here, psychological. So let's give 3 examples. So a 20-year-old woman has been married for 3 years. She has not been able to consummate the marriage and achieve penetration. She has been in long-term therapy with a sex therapist. She managed to introduce coach number 6. This coach is truly a very large coach. And when they want to examine her, she has a vagina. The entrepreneur is significant. She has the same legal cost and sensitivity in the vaginal opening. And she has a contraction of the pelvic floor muscles. The rest of the examination of all her components is normal. And she shows that she is succeeding in working with the largest trainer, so when we look again, it's a little general, but overall, we can see that there is a lack of other reasons for the pain. That is to say, she has no tissue damage or additional injury. Athletic. She also has no nerve involvement. There is truly a significant discrepancy between the ability to have a good coach, but the inability to allow even one finger to be inserted. One example. Otherwise, she is also a woman. Yes, we will need to. 12 minutes have already passed, so I wanted to say a word in conclusion. Yes, I will present here the 3 cases, and I will say that there are different cases of pelvic pain for one woman. Her pain is, for example, when she is under stress at work. But she doesn't have the pain when she is on vacation. Otherwise, we would have said she has pain during intercourse of a finger, but not in the trainer. It is here. An example of burning. I will finish, and I will say, with your permission, only another 1 minute. We see that the combination of pains, that they are complex with each other. That is to say, and here I will finish. If we take, let's say, a woman who has an episode of acute fungal infection and she is in a stable relationship, and she has not had a previous episode of fungal infection, then her pain level will not be very large. But if we take another woman who also has the same fungal infection, but she experienced a much longer episode a year ago, and ended a relationship as a result of that same fungal infection, and now she is experiencing the same fungal infection that her friend experienced, she will feel a level of much greater pain. The point is that it is very important to understand. Many times the pain component is not just one. There can be a woman who has genital pain against a background of yeast infection. But there is an additional plastic component due to a significant experience she went through in the past. I will end with that. I think it's a new perception for me, serving in a clinic to direct patients and assist with treatment and diagnosis. Thank you very much. Thank you, Orna. Continue, Orna. Dr. Michael Luria, expert in gynecology and sexual therapist, head of department. The Israeli Association for Sexual Therapy manages the Center for Sexual Health at Hadassah Ayin Karam. She is also a co-director of the Israeli Center for Sexual and Couples Therapy at the center, Rodam in Jerusalem. Thank you very much. Orna needs that you download the hair screen, please. Thank you. Okay, now we will search. Okay then. We started with good morning and now good evening. And thank you to Shlomi who is with us. So, essentially the next 10 minutes will be about trauma and pain. But mostly about trauma-informed, sensitive and adapted medicine. People are debating how to call it. To be sensitive and also adapt to people. Ours. So this is an article published in 2016, before the coronavirus, and when I saw him for the first time I was really surprised. That in countries like France, Sweden and the Netherlands, don't say the Middle East, 70 to 80% of people report having experienced a traumatic event. Not everyone will have PTSD. Of course, post-traumatic stress disorder. It's real, but people experience difficult things. I won't go into the details of everything. People experience accidents too. Why is this so common? There are many kinds of trauma. Can be personal trauma, like if I were in a car accident, or interpersonal trauma. Sadly, we encounter a lot of violence. And neglect in childhood, sexual abuse, of course, and poverty. We are, sadly, surrounded by losses in our country, certainly. And there are also collective traumas like war, natural disasters, and racism. You name it, there are quite a few. And what I really want to emphasize today is that being in contact with a healthcare provider can also be a traumatic event. The encounter between patients and caregivers, doctors, and all healthcare providers is an arena where many traumas occur. Therefore, we need to be aware. Trauma affects both those who have experienced trauma and those who provide care. And also, to avoid being the ones who cause trauma, we know there is a connection between trauma and pain. For example, in women with chronic pelvic pain, this connection exists. One example is that there are 3 to 4 times more accounts of childhood abuse. This is compared to women without chronic pelvic pain. For people after trauma, there are many health problems. Not just pain, but also dental issues and eating disorders. And various psychiatric difficulties, cardiac conditions, for example, are also a concern. There was a review published recently that essentially the highest percentages of people with fibromyalgia are found up to 70% in various series. That they are experiencing PTSD or post-traumatic stress disorder. People with chronic pain constitute up to 60% in certain series. That is the difference. It is very prevalent within the general population. Essentially, again, the connection between pain and trauma exists. We won't go into that. Time is slowing down. It's very important to me to talk about mindful awareness, even for those of you sitting in this hall, and healthcare providers will become familiar with it. How are you supposed to do it? And also for the general public. Also patients. Patients who know what they are supposed to receive from the doctor. Doctors who treat you, the physical therapist, and again all healthcare providers. So, essentially the principles are that in a trauma-informed examination, it should be one that fosters security and trust. We are supposed to provide a lot of information, be transparent, and provide predictability. Tell patients what's next so they know exactly what to expect. Also, give them a choice and control over what happens in the room and what happens to their bodies. After all, we are examining them. In medicine, ancient medicine forgot that the uterus, ovaries, and vagina are actually within the blood. Between a person and this person, there are rights over their body. And there should be some kind of partnership in some way. A partnership regarding the things we decide and do. and also some eye-to-eye understanding. And when it becomes like this, when it is done like this, the examination can be empowering. I spoke about this earlier. So, if we divide the examination into before, during the examination, and after. So, before, we need to ensure the environment is suitable. This applies to every medical encounter, that the door is not opened in the middle. I don't know where you work in hospitals. At health maintenance organizations, people sometimes come and go. Should it be locked or unlocked? It is the patient's choice. It's preferable that there isn't too much noise. It is essential that there is a curtain that actually gives the woman privacy to dress and undress and dress. And also that we tell the woman that she has the right to ask for a companion to be brought to the room. Before every examination, we need to ask and tell everyone whether they have a history of trauma. This trauma can be sexual, medical, national, or otherwise. Is there anything you would like to share? Is there anything you think is important for me to know about you? Is this a gynecological examination? Many women find gynecological examinations difficult. Is there anything you would like to tell me so we can do things differently? It is very important that we define and emphasize that we are asking these questions of everyone, regardless of age, sector, or gender, marital status, so that no one will say, "Wow, why are you asking? Do I look stressed to you?" No, I am asking everyone. And why am I asking? Because I can help. I can help because I can do my own testing otherwise. Or I can refer you to treatment if you would like. We were both dressed before too. The conditions were as equal as possible. Eye to eye, I will explain everything to her step by step. Which parts of the body are part of the examination? Why each step is important? I am inserting a specula. It is a device that, to explain why and how it works. It gently pushes against the walls of the vagina. It does this so that I can see the cervix. So I need to explain why I am doing everything. If I am using a tool, why is it good? Should there be some unpleasant sensation? I should say that. There is a brush to take a pap smear sample. It will feel a little uncomfortable. And how long does the test take beforehand? I also need you to ask for my permission before each step. And we both need to commit to staying alert. Because you might say it's perfectly fine. You check, no problem. But your body will tell you otherwise. And commit to being attentive to that as well. We commit that if it hurts, we will stop. And we will also ask if there is anything that can help you. As I already said earlier today, I care. And I recommend to you all to ask for and use a mirror. The mirror is intended for getting to know your body. Certainly, in a gynecological examination, many women have not yet chosen to use a mirror. As I said, it is important for the woman to be covered. This will allow her to describe every step of the way. I like to say, I turn on the light. Let the woman know what is happening. Ask for and receive permission before each step. Ask the patient how she is doing and if she is okay. Everything is fine. Choose your words carefully. There are women for whom, for example, the word spreading legs can be difficult. But if we say, put your leg here and your leg here and you lift it, your knees to the sides, it will be easier. Pay attention to nonverbal cues. And again, as I said before, if the woman expresses with her body that something is unpleasant for her, that she is not comfortable, at the end of the examination, be sure to clearly indicate that we have finished and are exiting. This is done to give her time to get dressed. Between, provide tissues and other essential items. It is a matter of human dignity for a woman who has been examined and has gel on her body. Give her something she can use to wipe herself and feel comfortable. And after the examination, we need to explain everything we did. Grazia, how was it for you? These findings, these insights. Are there any? Sometimes midwives Doctors, physiotherapists, they ask, they listen, they explain, they cover. They offer support. But sometimes they don't. They aren't aware. They don't know it's their role. Sometimes they don't think it's important. The staff is tired, busy, stressed, and worn out. It is very, very important that we all be an active part of implementing these things. To all healthcare providers present in this room, if you witness something that doesn't seem right, speak up. Sometimes in a large clinic with many doctors' offices, one hears a woman screaming. Or one can hear a doctor, or a female doctor, someone performing an action that is unpleasant and not in accordance with the law. Then you can speak up. Open up. Tell others. So that more people will know today. This is what the world changing for the better looks like. Or for the worse, unfortunately. But I also think that this awareness is growing among healthcare providers. And that is very heartening. May we continue to develop a professional community that is aware and sensitive to patients. Knowledge is power. It's not an empty phrase. It's true. There's a video here that was prepared with Lev Seiji and other physicians in the department. There's something like an access code you can use to film it here. It's a wonderful video with animation. It explains how a gynecological examination should take place. The goal is to encourage people to get checked. Women experiencing trauma stories are common in most hospitals in the country. There are teams that you can meet before giving birth. Do not go to people you haven't received recommendations for. And if you have good or bad stories regarding encounters with healthcare providers, please share your stories. It is important. There is the purple card. It is a collaboration of the Healthy Fund. It used to be the Social Association, Galit, for the advancement and treatment of sexual harm and prevention of sexual harm. This can be found if you do it through the Healthy Fund and the purple card. On Google, you will reach this card. You can download it. Medical appointments, and what is written here in 2 words. I was injured. Therefore, I ask you to listen to me and let me have control over the situation, so that I can feel safe. Also, every few months they publish a booklet of answers. The booklet is intended for survivors of sexual trauma. It includes all the services and options that the state and organizations offer. There is also a QR code here that you can scan now, and it will lead you. We're out of time, something like that. To sum up, yes. To sum up, I'll say that people really appreciate photos after an injury. It's actually a Japanese technique for repairing pottery. It uses gold dust. And there's another technique they launched for tissue repair, which is essentially, what it means is that sometimes repairing a tear, a trauma, or pain creates something even better, stronger, and more beautiful. Of a different kind. So, it's possible to grow even from trauma and difficult situations. In a quote by Victor Hugo, nothing is more powerful than an idea whose time has come. And this idea has come. Thank you very much. Thank you very much, Michal. This is how we summarize the session. We will answer a few questions that were raised here. I will start with a statement, Michael. This follows your lecture on recommending gynecological examinations following trauma. It's important to allow a woman to acknowledge her doubts. You want to say a word of apology about it. Yes, it's about giving a woman control over what happens in her body. And that is all. It also includes her guiding her own fingers. The midwife examines in the delivery room when checking dilation, inserting the speculum into her vagina. The ultrasound transducer. Certainly. and anything that will help her feel that what is happening is within her control. That is it. It's simply world-changing. With every word, it wasn't like this before. We would be happy to hear about treating cases of pain like this. There was no detail here. Is there something you would like to say about it? Something like that. The intended pain is nasoplastic. Presumably, essentially, that's what we are referring to. Pain, and not necessarily as a gynecological or psychological problem, as it used to be classified. This opens up the possibility for us to look at all pain mechanisms, and essentially we are not treating the pain. We are treating the person and incidentally with the trauma in the pain clinic. It's like what you did here. It's an exceptional thing. And it's so important to bring the pain of sexual intercourse in men onto the map. So many of those we see in the pain clinic with chronic pain are males up to age 12. The vulnerabilities are both in their sexuality and simply within the family. And certainly others are too. It's the same thing. In men, and often an expression that we ultimately treat the person. And we ask them the question sensitively. We hope. We check. How are they? What they or she think about it if it suits them. What we think it is, the treatment. Ultimately, we do it together. The team that is treating and who? The person who contacts us, that's also them. Even the patients are human beings. We ourselves are also treated for various things. Today, I didn't get to see my doctor because the clinic was overloaded, but ultimately we are human beings treating human beings. And the approach of breaking it down into categories to see where it affects me. What connections have been formed, for me because of the pain. Because of this condition, in the case of sexual relations, it's also not human to me. Rather, it's when we're talking about relationships that exist within a certain context. So the relationship, if it's with someone, with me in a relationship, then we are essentially. The idea here is to reach a personal diagnosis and tailored treatment. I will continue. Tali, what you're saying also connects with Michael. To what you said and also Orna generally speaking. Because it's knowledge, albeit seemingly new knowledge. But the physiological foundation has been known for at least 60 years. And things take time to become established in the clinical world. And as the information accumulates, and the clinical experience accumulates. But the importance, as Michael emphasized, is the significance of trauma awareness throughout the entire process. And as Orna talked about the importance of new knowledge. So the importance is primarily skill. Skill of the team in understanding pain mechanisms in perceptual judgment. In the ability to tailor a therapeutic plan. People ask us, yes, where do we treat? It is possible. We will gladly write, each of us in a different location. But the importance truly lies in the matter of skill and awareness of the mechanism. Another question that came up for you, perhaps Orna? What about pain that also involves tissue damage like endometriosis? Could there be a combination of tissue damage and nasoplastic pain? Or is nasoplastic pain always one that has no tissue damage at all? You can start, Orna, and I'll add something afterward. It's a shame, really. The end of the lecture was relatively quick. But definitely, and I learned this from Tali, we aren't discussing a single mechanism. We are discussing what we need to think of as a pleasant tool. We have 3 mechanisms. Which one contributes most to the complaint? And where to place it? The emphasis, and often it's a combination. I gave an example of a woman with a fungal infection, and it was her first time experiencing it. She is in a good relationship, and she will be examined quickly, and the level of pain was mild. She only had tissue pain against a background of effective fungal infection, compared to another example of a woman who also has just an event of fungus and it sits with her based on such a difficult past experience. So, it says that she also has additional pain. This pain is plastic, stemming from an experience and situation, a transition that left her with many fears and anxieties. In addition, she also has the fungus. She also needs it. She also has skin irritation. And I find in many patients that they have both. And it is necessary to know how to address each of the mechanisms. And once you reflect the mechanism to the patient, often it's a connection. The treatment's ability is very, very good. That is to say, you really see good responses to the treatment and to give each mechanism the appropriate response. So I agree with you. And I will continue with what you are saying. And I think I will take this to another content area. We know, for example, that people after amputations already change the map representing the severed area after just 1 month. That is to say, there is a very large difference between acute pain and apathy. You said it exactly regarding the issue that there is something new like a heart attack or a sharp injury compared to situations, for example, where there are lesions in endometriosis or other conditions besides endometriosis where there is a process that is recurring. And when there is a recurring process, the brain process changes accordingly. The understanding is that all pain originates from the brain, truly. The question is what the primary contribution of each part is. Therefore, regarding chronic pain, certainly on the background of a woman, the central issue is the inflammation of the tissue. We definitely see significant changes in the brain. Therefore, we also see other systemic phenomena, and not just the issue of, for example, pelvic pain. This is an important understanding, and I truly believe that we will continue to explore this. I tell many patients that the day is approaching when people who have suffered from chronic pain will undergo 2 scans. They will have a scan of the affected area for various reasons, or, as Orna mentioned, like any other investigations. And they will also undergo a brain scan, tailored, based on, and appropriate for brain function and the brain's pain network. This will take a little time, but we are definitely heading in that direction. We'll take one last question. Michael, if you'd like to comment on whether there is also a diagnosis of anxiety or OCD. Yes, that's how I am. I see that we're already moving on to the next session, so I'll also say that we know about CBT psychotherapy. Full mindfulness-based approaches, like various non-pharmaceutical treatments, can have a positive effect on pain, on anxiety, on depression, mindfulness, for example. You'll hear more shortly. The next topic we're currently exploring is the topic of treatments. And also a little bit. There are pharmaceutical options such as Cymbalta. That is to say, there are treatments available. Lips, but why answer questions? They say a good question is one where the answer is on the next slide. According to the following. Excellent. So thank you very much. And we will continue to the session. Thank you. Well, that's how we are approaching the end of this day. Where is the high gnome? I'm here all the time, I haven't gone anywhere. So, the 9th module is called Treatment Options. The first one presenting is Sharon Pelig-Nesher. Sharon provides treatment and guidance. She is the director of the Rodham Center for Couples and Sexual Therapy. She is also an oncology nurse by profession. To a dear woman. And just a moment, where are you? Sharon, will you speak with us? Where do we turn? What? How do we begin the journey of treatment? Please. So, I'll repeat the joke I made earlier because I don't know if the audience. Is it the same audience? This lecture hasn't happened yet. We'll allow that too. And we will also examine accessibility. Anyone who needs transcription because they are really struggling and cannot hear, they can go down into the 3 dots. Choose captions, and then they will have text displayed. That's amazing. I laughed to myself. Just a moment now, we'll upload the presentation. Great, now we're in the correct status. I'll move you with your permission. Truly, many times there's some kind of dilemma. It hurts me, it hurts us. Why is it even important to seek treatment? Pain in a sexual context is a multidimensional phenomenon. It includes, and this is said throughout the day, biological and interpersonal aspects, and the consequences of all of this is super significant for mental well-being. It also affects relationships. It's not enough just to live. Quality of life has great meaning, so we will also address the biological dimension, and the psychological dimension, and the interpersonal dimension. Furthermore, the World Health Organization has defined what it means to be sexual health, or rather, it also included elements as I mentioned: physical, emotional, and relational, cognitive, and also spiritual and cultural. And I will address that further on. When people come to a sex therapist's office, many women are embarrassed when they enter the room. They are not sure what to expect when they go to a doctor. They generally know they are going to a psychologist. They generally are. They know they are going to a sex therapist. They often do not know what to expect. Sometimes they come with unresolved issues. And one of the questions, the classic one that people ask on the phone, is whether the treatment will also include physical contact. In the room, there is often an opportunity to really describe the difficulty of letting go of all the pain. And when I ask a patient to tell me a little about the pain, I also see in her body some kind of moment, like excitement, like something. A joy that suddenly makes space for something she hasn't given space to before. And if she came with a partner, I often see in the partner's body language a turning towards her, and he suddenly becomes attentive to the world. That voice wasn't heard. That pain wasn't given a voice. Sometimes in the couple's conversation, it's the first time the partner understands and hears what she is talking about, and then that's when it happens. There's often a sense of relief. When we take a history, we are actually trying to address the cultural background as well, and the values, the myths, and the stereotypes that the woman or man carries, of course, along with their medical history. All the medications, illnesses. It's interesting how often, when I ask if you are a healthy person, so, if there are any ailments in the body, then you will say, but if there is a mental illness, often people do not mention it in response to this question. So, you need to ask if you are healthy in body and mind. Previous surgeries and treatments are not always linked to this. When I know that I have lung cancer, I receive chemotherapy. The chemotherapy causes me neuropathy. The neuropathy is the cause of the pain. It's just that sometimes the connection between things isn't understood. Or diabetes and pain, for example. Or if there was some trauma. And only now Michael told that people aged 70 to 80% of people define themselves as people who have ever committed suicide trauma. And its effect on relationships and marital status. And also, what are their expectations of us regarding treatment? When should they seek treatment for pain during sexual relations? When there is persistent or recurring pain, when there is emotional distress, when there is a sudden worsening, something unexpected suddenly appears. Sharp, abrupt burning, when there is an impairment in function, in the ability to maintain satisfying sexual intercourse, and this leads to avoidance of contact. When there is a marital impact that I am willing to grit my teeth through for some reason. This is not right. But there are so many women who say, I am willing to be in this place. But there is a partner there who is not willing to be in this place. And he is not willing to be on the side that hurts or causes pain. Even without improvement we tried. We bought it for him empty. With oil we oiled it. We put on gel. We changed positions. It didn't help. It's time to decide to take up the challenge. And not wait too long. Just as defining the problem is complex, so too is treating it. It is also done in a very arbitrary way. We will address here medicine, physiotherapy, and all emotional treatment. So when we turn to a doctor, there are, of course, the doctors at the health maintenance organizations. Gynecologists, endometriosis specialists, of course, you can seek them out. But yes, if someone knows there is some underlying condition such as endometriosis, it is truly recommended to turn to someone who holds that role. There are specialists in aging and vision, and female doctors specializing in pain. And I'll say a little more about that later. It's a vital and significant step in diagnosis, to rule out an organic cause or to identify one. We don't want a situation where we spend half a year discussing pain in the clinic. And then at the end we discover a septum or some other issue in the hymen that wasn't diagnosed. So, the examination as a baseline is something that's incredibly significant. There is pelvic floor physiotherapy. And it's not about sitting on a ball like in Pilates. Pelvic floor physiotherapy is physiotherapy that involves touch. And it's complex. Not every woman I suggest pelvic floor physiotherapy to is ready to begin treatment. But it is something that is said right from the start. There are pelvic floor specialists in every health maintenance organization throughout the country. There is eligibility for physiotherapy. Pelvic floor treatment funded by the health maintenance organizations is part of your coverage if you have insurance. Your insurance policies can also cover the physiotherapy. Please inquire there and also have an assessment of function performed. Please inquire there and also receive treatment for tone. Please inquire there and also learn relaxation techniques. Who should you contact? Is there a therapist specializing in emotional and intimate issues? They provide comprehensive and tailored psychosexual intervention to meet the needs of patients. In fact, in Israel and beyond, there is no license for a sexual therapist seeking to practice. Is a female sexual therapist qualified to do so? Something like that. And yet, we would still like someone to treat us. A professional. So I will also present that on the next slide. What will happen? Work on anxiety and avoidance. Emotional processing and integration of the partner. Because in my view, it's often not that she is to blame, but that he is suffering. The dynamic between partners often leads to pain and preservation. Pain and avoidance of pain. So, as you said, there are health maintenance organizations to turn to. There are also specialized clinics for sexual health, multidisciplinary. In fact, there are organizations in the country. One of them is ITEM, which is the Association of Sexual Therapists in the country. There are people there who are trained and skilled. ITEM refers to people who hold a master's degree in a therapeutic profession. Their training abroad ranges from 2 to 3 years. And they completed an internship of 2 to 3 years. That is to say, these are people who know how to work respectfully and with superb professionalism with the psyche. There is also ITN, the Association of Treating Physicians specializing in sexual health. This includes gynecologists, urologists, psychiatrists, and family doctors who have also studied the field. And if there is a problem with sexual function for a man or a woman, it is recommended to go to a gynecologist who also deals with this area. Or to a urologist who also deals with this area. Subspecialties or areas of interest involve intervention. A change at the front can change lives. I can tell you that there are patients who come to Rotem. They undergo a medical examination, and they leave with the feeling that it's a life-changing examination. If it is done correctly, it's an explanation, respect, and sensitivity. It's truly a different experience. The response needs to be multifaceted. There are pathways. The goal is ultimately to improve quality of life. I will upload this slide again. We have a webinar on May 20th. It is part of today's wonderful international continuation. Thank you very much. Michael, we don't hear you. Thank you, Shlamet Arbel Emmanuel. The next speaker. Shlamet provides therapy for individuals, couples, and families. She specializes in trauma treatment. She works in a private clinic and at the Rodham Center. Shlamet teaches in training programs and for therapists. And you won't believe this, but everyone who is from the settlement and is here today, both behind the scenes and in front of them. Shlamet, thank you, thank you. Thank you very much. This is the stage I am praying for a miracle. I hope this will share a part. Just a moment, of course this won't happen in 1 second. Before. First of all, thank you again for this day. All the speakers. I am a therapist specializing in individual, couples, and family therapy. I work from a systemic approach. That's me. I meet daily with the sensitive interface between body and mind. I primarily work with women. What about men, and more specifically women and their husbands and wives? Most people want to eliminate the pain. One woman once told me she came with pain related to penetration of my body. He is betraying me and I want him to stop. She wanted to eliminate the pain. So I don't want a celebration to say that pain is something we want and desire. But the importance of listening to our body's pain speaks. And when you don't listen to it, it speaks louder. And when you don't listen to it, then it really screams. And of course I will emphasize again in a sentence what was said before. Of course, a physical examination will come to me first. Once a patient was my third emotional treatment. And no one sent her for an examination first. Indeed, she also had something physical. But even when there is something physical, the mind is affected by it and then treatment from that stage is needed. That's when I am. I request to offer a perspective today. The pain is not some malfunction that we need to fix. It is a kind of gatekeeper that we want to listen to. I work with body-based methods within the focusing and somatic experience framework. In combination with. And in the coming minutes we will delve a little into this focusing SE. And how to work with it regarding pain. So, I will begin with a short poem by Yona Wallach. I really love it. My body was wiser than me. Its capacity for suffering was less than mine. Said enough when I said more. My body while I continued on. My body could not fail. And I rose and was forced to leave. So the pain in psychotherapeutic treatment is from a body-based stage. We believe that the body and the mind are one system. And the pain, a solitary day within the tissues, is actually telling us about our boundaries. It is telling us about past experiences. It is telling us about memories. It is telling us about traumas. And it is telling us about the basic need of our body and our soul for security and function. Body-based therapy allows the patient to truly transform this pain into something that provides information, and that it holds meaning for the needs for the security. Instead of fighting the pain, we begin to ask it, what is this pain trying to tell me? What is it protecting me from? We are essentially approaching with curiosity to speak with the pain, and beginning to build a relationship with our body. Our system, when there is pain, our entire system. The way pain actually activates the sympathetic system. And that is the same system that operates in trauma, the familiar fight or flight response. It operates during times of danger. The body is tense and ready. In response to chronic pain, the sympathetic system can remain constantly active. It's as if there's an alarm, but someone hasn't removed their hand. The alarm and the body are constantly saying, present, help, help, danger, danger, danger. And not letting go. And what we do in body-based treatment methods is essentially activate the parasympathetic system. The parasympathetic system calms the sympathetic system. Sometimes the alarm needs to go off. But it doesn't need to be on all the time. We are essentially creating a space. Within this space, a woman learns to trust her body. She also develops with her body a relationship. As we discussed earlier, looking at the system systematically, the system is not within the woman's body. She is a man with a problem of premature ejaculation or erectile dysfunction. I will warmly suggest to him her partner. I will also suggest bringing her partner in for pain management, because the pain is part of the couple's system and is not the woman's problem. Sometimes it feels as though the woman is being sent to fix herself, and then the man will return to treatment. So we don't fix anyone. We work with the system. And of course, as was mentioned in the previous session, this is work trauma. I won't repeat what was said. But integrated bodywork is proving to be very beneficial when working with trauma. This is very, very limited. This is very, very important, because trauma is stored in the body, and the energy of the trauma remains in the body. It is important that we also incorporate the body into the therapeutic process. So, I will go over some very, very basic things from two areas that I enjoy. I work with them. The first is focus. Focusing. We will use something and I'll give you a short demonstration of it called felt sense. Felt sense is in Hebrew a felt sense. It's essentially a feeling, a bodily sensation, and a sense of what the body is telling us. We learned that there is pain. After all, my pain, my friend's pain, and my girlfriend's pain are not the same. So, we essentially learn to give pain words and images. Sometimes it will be a color, a shape. We will soon learn to truly create a dialogue with the pain through the body. We will feel it in our bodies for a moment, a somatic experience. SE essentially means that we are relating to the pain. We are treating it as a survival response, a freeze response. And this item is stored in the nervous system. And what we want to do is release it from our nervous system. The pain is the symptom, but what we want is to release it from the nervous system. We will do this through two basic means. One is called iteration, and the other is called intuitive attraction. We will essentially take small doses of the pain, of the difficulty, and we will work with them. And at the same time we will take many resources. And in this way we will move the attraction. It's a little pain and a lot. We will also define, alongside working with the pain, we will also define our sources of pleasure. Our body is also a source of pleasure. Our brain takes it and turns it into pain. But we will also place emphasis on its pleasure. And the aspect of variation is essentially the movement between pain and places. It can be pleasure in the body. It can be other resources in our body. And this movement is essentially the very creation of that movement. It usually begins to lower the level of pain. I will only ask those who are here until what time I have so that we don't get delayed. I want to stick to the schedule. I think 36 maybe or 37. This is how you created me in 10 minutes. Even good, so I'm already checking and saying I want to. Just a moment will do it. 1 minute or close your eyes. Or for a moment identify in some point. Just a moment, even the way you're sitting with your body on the chair. Feel the touch of your back against the chair. A comfortable place in your body. Even if it's the tip of your fingernail, pay attention to it. And then we will do it a little faster. Of course, usually it's slower. Pay attention to the place on your body that is currently uncomfortable. It could be painful, tense, or cramped. And just notice the cramped, painful, or uncomfortable feeling. With curiosity. And see if you were to give that feeling a word, a color, or an image, what would it be? Perhaps it's like a spring, or maybe a certain color. That's the nature of this feeling. Just take a moment to notice the feeling of ease, and see what happens when you simply exist with the uncomfortable feeling. Does something soften a little? Does air enter your body? And now let's return to the place we started from. It's a comfortable place in your body, or the touch of your back against the chair. And slowly, we will close our eyes and return here. Now that was very, very quick. And of course in the clinic we do it slowly and give it time. But this is a small taste of what happens in our body, really? What did we just do? There's a poem by Yehuda Amichai. Precision of the pain and blurring of the happiness. The mind leads to the pains, and we want to work with the pain as well. And also to acknowledge to the body its other places, even if only the tip of a fingernail of comfort. Simply giving attention to the painful place is already beneficial. Breathe a little air into it. Sometimes it will scan some energy that is within it. If there is some trauma there, it could manifest as a tremor. And so on. We will work with it gradually. That's how I am. In a minute or two, I will tell you about a 32-year-old patient who came to me suffering from pain during penetration. During a gynecological examination, an explanation for the source of the pain was found. She is married with 2 children. It was resolved quite quickly. After a few meetings, I began to integrate the body into the work. When I asked her how she was feeling physically, she told me nothing. And she experiences great frustration from the fact that nothing is happening for her physically. But then I asked her where the frustration was located. And she said in her chest. And I asked her what it felt like. And she began to describe what this frustration felt like. A wave of sadness washed over me. I asked her if this feeling of sadness was familiar to her, and everything. We work with feelings through the body. It is familiar, she said. Every time I see my father speaking to my mother. Or this feeling of sadness, it stems from the complicated relationship my father had, and the deception that arose from it. A strong feeling of helplessness, a sense of not knowing how to help her mother, and a great fear in the body. What will happen if I don't notice everything that is happening now? About a mother, 32 years old, a mother of 2 children. If I miss something. And then she said, I'm afraid of losing control. And what happens when you are afraid of losing control? She swept it. That, and she said, I build a wall, I build a brick wall. Where is the wall? I asked her and she said, here. She pointed to her pelvic area. And what happens when you approach the wall? She pushed her hand and said, no one is allowed in here. So what happened here with her intervention was not to try to break down her wall. I essentially refrained from asking her if this wall was male. We need to finish. I'm finished with this wall. And she said, he would say that he protects against danger so no one will come near and so on. I won't go into further detail, telling the story slowly over the other 2 meetings. And after that, the whole complex story of her family and everything that followed. 2 or 3 sessions we worked with the body and the pain. The intensity of the pain began to decrease. It wasn't magic all at once, but the intensity of the pain started to lessen. So I'll say, healing pain related to sexual intercourse doesn't happen through willpower. It also doesn't happen through trying to subdue the body, or through our criticism of the body, or through a feeling of brokenness. Rather, it happens through rebuilding trust between the woman or man and their own body, building a relationship with the body. When we allow the nervous system, we enable it to feel safe enough. It will lower the defenses and the pain. It will gradually make space for connection as well. And I invite us all therapists and caregivers, and others who suffer, to stop fighting the pain. And may our bodies enter into life. He, our most beloved Father. Thank you very much. Thank you Shlamet. Thank you very much. The next speaker is Michael Dvash. She is a social worker and a graduating intern at the Rodham Center. She treats patients in a clinic in the Moshav of Lachish. She manages a cluster of 2 flagship programs at the Gvanim Association. One program integrates people with disabilities into the Israel Defense Forces through the Back to the Future program. She provides community support for people with PTSD, which occurs within a military context. And Michael will tell us what sex therapy is. Thank you, Michael. Well, I just wanted to share that with you. You can see the presentation. Excellent. So goodbye, everyone. This conference is a real opportunity to address and discuss sexual therapy. So I have 10 minutes. I decided to write because 10 minutes really needs to be very concise. So I'll dive right into the sexual treatment. The focus is on sexual treatment of pain issues. So, in a lecture on sexual treatment, it's impossible not to say a word about the pioneers of sexual treatment. But just to show a little where we were and where we are today. Exactly 120 seconds on this thing in the 60s and 70s. Masters and Johnson began to explore sexuality from the physiological perspective. The behavioral aspect emphasized understanding how the physiological system works. That was sexual treatment. Accordingly, it was possible to understand the dysfunctions throughout all the stages. They outlined a linear model. The model identifies the stages of the sexual response. It includes 4 stages. We are talking about arousal, plateau, orgasm, and resolution. That is to say, the pain disturbances appeared on the same sequence of 4 stages. For example, a stage can occur, say, in men. Pain during erection is an example of how it progresses. Water jumps during the time. They move on to Rosemary Benson. She passed away just last week. And she really did. She revolutionized a perception. She moved us from a linear model, and mechanically and physiologically, to a circular and possible model, when, in essence, the greatest contribution is, hers is femininity, certainly female sexuality. She is not driven only by biological urges. Rather, it is a truly holistic experience, with a desire and need for intimacy, for closeness, for security. That is to say, these things suddenly entered the model, and they stopped being merely physiological, and within that she essentially is, giving us an example that motivation and emotional context are, let's say, arousing. She developed, let's say, the hypothesis of not focusing only on the physiological aspects, rather on truly restoring vitality and pleasure. And sorry. Another example, as Sun mentioned when referring to pain issues. So she didn't speak only about the physiological aspects. For example, physical therapy salaries, things that came up today. For example, a complete cessation of touch in areas that are painful. Or to teach partners to create places of intimacy and pleasure that do not involve penetration. I'm jumping forward in time and we are talking now about modern sex therapy, which today is very rich and varied. I will give my example. I will detail other styles and ideas later. For example, I treat using David Schnarch's differentiated approach. And he also made a very significant leap in the understanding of disc function correction, and he brings a perception of growth development. For example, let's say difficulty with sexuality. And in the Kava, it's not just a physiological problem that needs to be solved. Rather, it's truly an invitation to a deep encounter with ourselves and with our partners. Through treatment, a person goes through a real journey where he discovers and learns about his unique self. He learns about desires and boundaries. But this doesn't happen only with the self. It truly happens within the connection with the person we want to be close to. And in that connection, it means that today we would like to eliminate the pain. That is truly the dream. But actually, we do use the pain in therapy not as a solution in itself, but truly as a lever for self-development, self-regulation, and communication that allows us to truly bring ourselves honestly. This came up for me today as well in the model. I will explain what is happening in therapy. I will also talk about its progress. That is to say, there are therapies today that we have within the theoretical model. But it has actually taken place within the therapy room. It allows us first and foremost to really talk. To be given permission to talk about everything within the walls of the therapy room. Everything is heard. I will elaborate shortly on what that means by everything. But it also allows us to give information that is limited. For example, about contraception. For example, about sexual phenomena that can be normalized. Like, for instance, the percentage of men and women who experience pain. Men who are heard in the treatment room. Men who have. And so, percentages of men who experience pain really change the way they relate to themselves. Simply providing the information can be really critical in the healing process. It allows us to also give very concrete suggestions like, as Shlamet also said, take a moment and seek treatment. A gynecologist, it's traumatic? Or a pelvic floor physiotherapy appointment. These are very specific things. And I will also say that the final stage of the model really addresses sexual therapy. It requires depth and expertise, and it allows us to really directly talk about the pain as well. What do I mean by talking about everything? Talking about everything? Really, that means every thought that goes through our heads. Those words we sometimes struggle to say even to ourselves out loud, or to our partners, can be really difficult sometimes. But the ability to talk about the pain, to pinpoint where it's located, how it feels, to talk about wetness, about organs. We will introduce terms that we will definitely adapt to a gender transition. A cultural adaptation to the way people around us talk about these things. But simply by being able to bring sexuality into the treatment room, we can really see the air enter the lungs, the honesty that comes with that air. And that really allows us to lay it all out in the room, to put things as they are. What happens in sex therapy when that is present? Is it intense? So, as we saw throughout the day, first of all, it's about stopping the action that causes pain, like when we give permission to talk about sexual matters in this way, we are giving permission within the therapy room. We are allowing you to put the pain aside. It doesn't mean it's not there. And it doesn't mean it's absent. It means it is. It's what is happening right now. But his assumption aside allows for it not to be. The meaning is that a woman or a man says they are not ready to continue bearing this pain. It is truly critical in their healing and personal growth processes. And this means it will allow bringing exposure into the room, understanding what feels good to me. And this means not only understanding what feels good to me, but also being able to ask for that which feels good. It will allow starting to talk about personal perceptions of sexuality for each of them for her. Even, it allows making the change in perception. For example, my body image with myself. What I think about my body, and maybe slowly but surely also learn to love my body. Despite the pain, it's about recognizing each person's personal sexuality, bringing forth a sexuality that is different, one that hasn't existed before. That means there are many times when I experience pain, so there's a very significant reduction in her sexuality to restore parts of it. And also to learn which other parts of the body, yes, bring me pleasure. So I'll say the treatment continues for a minute. Just a minute, I'm almost finished. I'll say what else about sexuality sexual treatment brings. I think that was the first thing that came to mind when I thought about it. This lecture brings pleasant things. It also brings a lot of embarrassment and experiences. Not all of the experiences will be successful. But the very fact that you can laugh and make it something more playful allows for it actually means that it has a new playground. You can explore it in a positive and good way. I will say that intimacy is not just what happens in the room. What does that mean? It means that it also includes medical treatments, physical therapy. If it refers to all kinds of exercises, it could be sensational. Focus can be appearance. Can be books. Can be experiences in bed. Can be a very, very, very diverse range of sex toys. And our goal is to allow them to open up the possibilities and their minds to the fact that it is possible. And that is it. And I'll just say that sexual therapy, in my opinion, is a real gift when couples come in. I am truly happy for them. Because the meaning is that they will not carry those pains for 10 or 20 years. Or to narrow down their sexuality. They understand that sexuality can really be different. And they are willing to work on it. Inspired by the plasticity model. I give permission to patients and the people around you to seek sexual therapy and to receive it as a gift. Thank you very much. Thank you. This is me. Happy to invite Lytle Laszlo to pelvic floor physiotherapy for women's health. She treats women who have impairments in the function of the pelvic floor. In a private clinic in Jerusalem and in a clinic and a practice, full disclosure. This one is mine in Modi'in. And Lytle beyond that. She is also involved in research in the field of pain during sexual relations. Her master's degree and also now. She will begin a doctorate. We asked Lytle to explain what pelvic floor physiotherapy actually is, and what is done in this treatment. Let's begin. What do you do in pelvic floor physiotherapy treatments? What is physiotherapy? It's a professional field. Healthcare as a paramedical profession is based on science and research. We are involved in both the diagnosis and treatment of all issues related to the movement system. This includes musculoskeletal, nervous, and soft tissue. After studying physiotherapy, one can undertake specialized training in the field of treating women throughout their life cycle. We deal with this central area, the field of pain during sexual relations. I will expand on this today, including complaints in the urinary system such as incontinence rehabilitation, postpartum recovery, chronic pelvic pain, and so on. And there is also the field of pelvic floor physiotherapy for men. This is a field that deals, among other things, with pain and dysfunction of male sexual function. A little about pelvic floor muscles. Professor Lev spoke about it in the first part. She discussed the issues in the first lecture. But I will say two things that are important. We see that many of the patients who come and much of the public don't understand enough what we are talking about. It's called pelvic floor rehabilitation, pelvic floor muscles. It's a kind of group of muscles located in the lower part of the body. They are located in the lower part of the pelvis. Here we see a woman standing with her face to the right and her back to the left. There are the three systems of the pelvis. These include the urinary system, the sexual system, and the reproductive system, and the energetic system. And at the base of all of this are the pelvic floor muscles. Pelvic floor muscles can contract voluntarily. That is, I can contract and relax my muscles. But they also have an autonomic function. The body contracts and relaxes. In his opinion, they have many roles. Two roles relevant to the story of relationships are, first, that they function as a clamp. And then, during contraction, they really reduce the circumference of the sheath. And then, during entry, there can be a real sensation of blockage and a sensation of pain from strong stretching. Contraction during relaxation, of course, involves much more movement. There is a capacity for flexibility, and then the entry won't hurt. The second thing is that they also have importance in sexual function. Proper muscle function can allow for the attainment of pleasure and orgasm. So, proper function includes relaxation and contraction. Most women who maintain pelvic floor physiotherapy go directly to the contraction point of Kegel exercises, contracting to become stronger. Most of the problem in women with pain during intercourse is actually the opposite. The muscle is in a state of excessive contraction. This isn't something the woman is doing voluntarily. It's a primary response to some orthopedic issue. Something related to the stabilizing muscles. A problem connected to bowel movements, constipation. There are many factors that can cause excessive contraction. And then the muscles are in a state of excessive contraction. And there will be pain upon entering the vagina. The second reason that is connected can be secondary. And that's why pelvic floor physiotherapy is so common in treating sexual relations. Because almost any reason that causes pain during relations after it has happened once, twice, 3 times, the body will learn that entry is going to be painful. And then the muscles contract as a defense mechanism. This contraction will cause more pain. The pain will cause more contraction. Therefore, the moment a woman experiences pain during intercourse for a period of time, her physical condition usually worsens as well. And we almost always see excessive contraction there. The initial treatment for excessive contraction is physical therapy for the pelvic floor. So we want proper function, both of relaxation and of contraction. And what is usually done in the case of pain during intercourse is also to teach the body relaxation techniques. And to really treat the muscles and bring them to a proper state, a state of rest. A healthy muscle also contracts as it should, and heals as it should. It's not one at the expense of the other. So what do we do in treatment? First of all, do we want to understand the problem? What is the patient's medical background? We perform a physical examination. She also has a general muscular and pelvic floor assessment. They are part of the whole body. They are part of the postural muscles. They work together with the breathing muscles. They are connected to the abdomen, intra-abdominal pressure, and abdominal muscles. Can affect things, so we are doing a general examination. And also a local examination usually. The treatment also involves an examination and internal treatment through the vagina. We explain about the anatomy and also about the function many times. The first thing is to understand. It is to see with your own eyes. It is to understand how the body works. Behavioral guidance. There are many behaviors that can be related. For example, physical activity habits. For example, bowel movement habits. So we also want to see what is related and contributes to this physical problem. Manual therapy techniques are really our area of expertise. Therapeutic work, hands-on work, also on the pelvic floor muscles both internally and externally. And if there is a membrane, then techniques to soften the membrane. If there is the hymen, and also anything else that was mentioned previously. If there is a stiff scar, then various techniques to soften the scar. For functional learning, you can use either biofeedback or ultrasound. These are 2 devices that show the patient what is happening when she contracts, what happens when she relaxes, and then she has the ability to learn motor learning and help the body reach a relaxed state. Also, recommendations and stretches specific to the pelvic floor. And again, in relevant joints according to the patient's complaint. A tool to aid treatment. Vaginal trainers is something we use a lot. It is very common. This is a set of 8 trainers. This specific set is received free of charge from the health funds. We can adjust the size to meet the patient's challenge, and then two things are possible. First of all, exercises involving stretches can be done both in the clinic and later at home, or for the muscles, or to avoid, or for the scar tissue, or again, according to the patient's specific issue. And she can also learn insertion into the vagina without pain. Because there is a gradation in size, and a gradation in the circumference of the dilators, she can experience vaginal insertion that is not painful. And then, if it is, to progress gradually. And essentially, it's some kind of exposure to the brain for painless insertion. Or so that the body becomes so accustomed that everything inserted no longer causes pain. And even if she practices many times alone, she has a lot of control. It's some kind of experience that is a corrective experience. Using vibrating accessories also somewhat dulls the pain. And then it eases the treatment and the practice. And sometimes, if there are issues with sensation, it can be stimulating and helpful. For rehabilitation, it's an anesthetic for very painful patients. We can do both the treatment and the practice at home. This will be done under some local anesthesia. And then the experience is better and easier. And with fitness equipment, we work on the body as a whole as needed. We also utilize this. Points to consider for treatment. First of all, the treatment is a process and is personalized. We don't have a protocol that we apply to all patients. According to the needs, both physical and emotional, of the patient, we can conduct the treatment. Most patients report having a very positive experience with their bodies. Although we are dealing with pain here, although it involves intimate exposure, the therapist's relationship to the body and the processes she undergoes, and the fact that she sees improvement, and she is able to communicate with her body, she is able to work with it, and the body is progressing and less painful. It is an experience that she finds very uplifting. She strengthens her confidence and her self-image. This body is the opposite of all the negative consequences we discuss throughout the day. What happens when a woman suffers from pain in relationships? Treatment usually involves internal therapy. It also includes treatment within the vagina. But there are two things that are important to say. Many patients worry about this. One thing is that the patient dictates the pace. Sometimes it won't be part of the first treatment, and not in the second treatment, and sometimes it won't happen at all. This is not a reason not to come for treatment. We can help both externally and in other ways. It is very effective though, and it is usually part of the treatment. But the patient is very worried that it won't be avoided. If we see that the treatment is not progressing at the pace we want, we will refer to the doctor. We will request a consultation if additional intervention is needed. If emotional or marital difficulties arise, we will refer accordingly, and also according to the patient's wishes and consent. Sometimes there is communication between the therapists to maximize the effectiveness of the treatment. The treatment is sensitive to trauma. It also addresses sexual trauma. It also addresses trauma from any medical examination experienced as painful. And often, it is precisely the progress in the body and the sense of safety in the body and the painless experience that advance other therapeutic areas as well, such as emotional therapy or psychological therapy. This treatment is available through the health maintenance organizations. It is also available in physiotherapy clinics and in hospitals. The financial contribution here is minimal. In some of the organizations, a referral is required. It is usually quite low. This is the disadvantage here. And there are also the private clinics. It is possible to access them with an initial referral. You don't need to go through a doctor. But if it's a complicated case, there is already pain here for a long time. We do prefer that the patient comes after the medical diagnosis. Sometimes reimbursements are available from private insurance or supplemental insurance. Every woman should check what she is entitled to. How many treatments are needed varies greatly depending on the complexity of the problem. The average is between 2 and 7 treatments. But in more complicated cases where the woman has been suffering for a long time, it can also reach 10 or 15 treatments. Research, we see that after physiotherapy treatments, pelvic floor therapy also results in a reduction in pain and an improvement in sexual function. The experience. Extensive clinical experience and research evidence both point to physiotherapy as an effective and well-established treatment tool. Patients generally report a very positive experience, and it really does help to completely alleviate the pain. We are here for you. You are welcome. Thank you very much and well done for your punctuality. Our next speaker is Dr. Angie S08, an obstetrician. She is also a specialist in vulvar and vaginal diseases. In addition, she specializes in cervical medicine. Dr. S08 is responsible for day hospital services. She is also responsible for the cervical clinic at Northern Hospital. Furthermore, she manages a private women's health clinic in Naf Hagalol, and she will present innovations in treatments. And most importantly, what should we be careful of? And the rectum has been a truly fascinating topic so far. I will try to stick to the schedule. The screen. You see the screen, you hear me. Yes, you see and hear. Wonderful, great. So, I am going to talk about treatments for pain during sexual relations, and new developments and what to be careful of. So, complexity in diagnosis presents the significant challenge. Disappointment with the results of treatment, and a lack of readiness for multidisciplinary treatment, often leads the patient to seek miracle solutions. We have a good arsenal of evidence-based treatments. The lecture aims to present new treatments, not those that were discussed today during the conference. These new treatments have entered the market in recent years. They are less well known, and there isn't always sufficient information available about them. Would you like to proceed? What is the rationale and what information do you have about them? So, the first thing I am going to discuss is dealing with shock waves. So the biological rationale behind this is that there are waves, pressure, which encourages and promotes the creation of blood vessels. They also encourage the creation of an anti-inflammatory effect. In addition, they contribute to reducing nerve sensitivity. I have proven cost-effectiveness in other areas, such as erectile dysfunction in men or Peyronie's disease. What is the clinical evidence regarding pain during intercourse? There are 2 controlled studies that actually came from Rambam Hospital. Both showed a real benefit over extracorporeal shockwave therapy. However, it is important to say that there are 2 studies on a very small number of patients. We treat 30 patients in each of them. A more recent meta-analysis also showed a relative benefit, but, compared to energy-based treatments then, the significant limitation of this method is that we are talking about 2 small studies. One of them is a longitudinal follow-up, a short-term study that lasted 4 months, 3 months without a standard treatment protocol. And there is no comparison to more established treatments. So treatment does offer promise but is too early for routine use. What is Botox? Actually a muscle-paralyzing toxin. It relaxes the muscle. It has indeed been proven effective for overactive bladder, muscle spasticity, and migraine. There is research on pain relief specifically in certain areas. Studies of very good quality demonstrate real improvement in the tone of the pelvic floor muscles. In terms of sexual function, but there is very significant variation in the research regarding injection protocols. There is no single, universally agreed upon protocol. Sometimes it is used. The use of testing is employed. A physical examination is performed. We are impressed by the area with increased tone that triggers the pain, and an injection is administered there. There have been recent studies, guided by EMG. This is an expensive treatment. It is not covered by the healthcare basket for this indication. So, it can truly be reserved for cases of hypotonia and reflexes that do not respond to treatments we provide in pelvic floor physiotherapy. Radio wave therapy is interesting. It involves thermal energy, heat energy. 2 transducers are used. One is inserted into the vagina. This creates an electromagnetic field. The electromagnetic field generates heat energy, promotes collagen modeling. It also revitalizes blood vessels. There are indications in single neurology, dilation, and post-Norway. Regarding pain in relationships, there are essentially no studies. CT scans are either controlled, but there are good short-term results. So, there is no research evidence of effectiveness for pain in relationships. The reference is to strong Jewish identity, but it is possible. It is possible to say that it is also a promising direction in certain cases. So what about CO2 laser? There are several types of laser. I will touch on some of them in the lesson. So there is the marketed biological rationale. Essentially, it involves thermal damage. It was presented as encouraging tissue regeneration. As an option and marketed as a non-hormonal option, this treatment is invasive. So, the initial results were truly impressive. However, without a control arm and expertise from the companies that manufacture this equipment. But in recent years, higher quality research has been added. And with it, the effectiveness has decreased in the results. And the ECHO's recommendation is essentially that further comparative studies are needed. And it recommends not to use it routinely but only within a research setting. And what do we know about cold laser treatment? The biological rationale is that it involves non-thermal energy. Please note, in contrast to what was presented earlier, there is a reduction in inflammatory mediators. There is also proven effectiveness in pain relief. There is also proven effectiveness in literal muscle tissue. Furthermore, it has a very broad safety profile. Otto's laser. Essentially, we have 2 studies. Both are by Professor Levseji. They demonstrate a very significant improvement. Almost 78% compared to 44% in my studies. A statistically significant level of 0.04 and more. A controlled study that improved allodynia pain threshold from 25. So, the initial clinical data are very promising. However, they are based on a small number of studies. Therefore, further validation is required in this case. In contrast to the non-laser, there is also land here. But it still represents a limited body of evidence. Hyaluronic acid, yes, that is in use. Why, I do not know. It involves hydration for tissue healing, anti-inflammatory effect, swimming pool effectiveness. But whether it's a swimming pool or pain in relationships, there isn't really that much of a connection. So this is one of the treatments offered. All the evidence from uncontrolled studies suggests that pain mechanisms and relationships are not affected by hydration alone. The recurrence rate is very high, essentially. It's an effect that isn't entirely lasting. There is no convincing biological rationale for pain in relationships. So what about cannabis? There are some individual receptors and expression in vaginal tissues involving modulation. Pain, inflammation, and muscle relaxation. It sounds very promising. A very large market of women buying cannabis privately. And to date, there are no good studies or works that demonstrate the effectiveness of cannabis. Regarding the complaint of pain in sexual relations, there is insufficient data to recommend clinical use. So, biologically it does exist but without sufficient clinical evidence. And there is no blanket recommendation for its use. In research, there are developing therapeutic avenues involving medications that attempt to treat the symptom of pain with medication. They are trying to address the underlying cause, which is the nerve and the inflammatory process. We will follow what develops in the coming years. So, what is truly important to remember? First and foremost, an accurate diagnosis. Every woman has the unique aspects of her own problem. So, first a diagnosis and then treatment. And remember that women are different, and that indicates different challenges. Choose evidence-based treatments whenever possible. Precision. In diagnosis, it is what produces the success of the treatment. So, it is very important to me in this lecture to convey that one should avoid treatments that are not evidence-based. And to be mindful of treatments whose marketing precedes their effectiveness. The cookies. Thank you. Thank you very much. I just want to say that regarding hyaluronic acid, you didn't emphasize that. But these are hyaluronic acid injections. Something that has really emerged. It's come about in recent years, not very clearly. It's without any studies. They hype it up. Our next speaker is Yasmin Boaz. Yasmin is a coach and group facilitator. She accompanies individual and group healing processes from pain. She accompanies individual and group healing processes from nasoplastic symptoms. She is a member of the founding team of Campus Mibrashit, led by Dr. Efrat Surakwi. She is part of the emotional learning team. She is also head of the mentors and alumni sector at the campus. In addition, she works in a clinic with me in Modi'in. She also works at the Yasmin Clinic and in its clinics. She herself is recovering from pain, among other things, from pain during sexual relations. In her work, she integrates nasoplastic knowledge. It also combines emotional understanding and learning and change processes. She will discuss group treatment for pain issues. Thank you. So we'll see this full screen. And we hear and see wonderfully. So good evening. It's very exciting for me today. It's also nice to accompany him, even in a professional setting, but especially in my personal space. And today I want to talk about a group model for healing from pain, and things that we also do on campus. And essentially, one of the most important things I want to lay out in these few minutes is actually the voices of those who have recovered. Of people who have dealt with pain related to sexual experiences and have healed from that pain. And through that to guide the knowledge and the group learning, also in understanding what they bring regarding the effectiveness of the work. Compared to the treatments they've had in the past, so as to establish that, first of all, it's about a stage that is somewhat different in this context. regarding work with nasoplastic pain, which was discussed in the previous panel. So, part of the process involves avoidance in building a new routine, and learning and changing reactions, automatic responses to pain, something that requires a great deal of proactivity within the process. Therefore, perhaps one of the first things is distinguishing between learning and treatment, because in learning you are expected to be more present, more involved. Learning is a process that focuses on the program but clearly outlined in the syllabus, and less on addressing the symptom that I encounter. It's less about management and alleviation. Goals toward healing from pain. If there is a student and there is a facilitator or teacher, then there is a lesson. And one of the things we always include within the meeting is also the place for what you learned. Today it is what I am taking away from the meeting each time. My ability to internalize and gradually build a toolbox is a focused and concise process. Short term. In this context, the goal is to build some kind of toolbox and skills. It will be possible to continue because there will probably be other things in life. Perhaps not chronic pain, but within our ability to develop capability and ask the right questions, and to consume different medicine and receive other treatments. So the first thing, perhaps the most significant thing I heard, was what survivors told me after I gathered their testimonies on campus. This sentence. The first thing I didn't need on my healing journey from pain related to sexual relations was new knowledge. The knowledge allowed me to rebuild confidence in my body. She means by that to study pain mechanisms, to understand threat systems in the brain, to understand the pain network. And actually, knowledge of this can already be seen in the initial stages of the process. It's really disheartening to experience symptoms even before anything is done. Additionally, this helps us break down paradigms and initial core beliefs. And essentially, it allows us to create a new belief regarding what pain is and why I am hurting in sexual relations. But many times, people are completely reluctant to talk about groups. And they have good reasons, because what we know today about groups are usually groups that we can see on social media. And support groups themselves are groups whose foundation is a medical diagnosis. It's the foundation of suffering. It's the foundation of coping. And let's not put that here in a place where it might not be appropriate. Everything is fine. But it doesn't help to promote healing because of perception. The foundation is that pain is a predetermined fate. Many times this creates even more stagnation. This week, I heard from someone who just started a group. To what extent? To what extent did it increase her fear and her doubts? And to what extent is it bad for her to be present in such groups? So, with this understanding, to feel less alone? Because pain brings us together, especially pain related to intimacy, to a feeling of loneliness and a very exposed feeling. Like throughout this day, it all came to the surface. An expression, so to feel less alone doesn't mean staying in the same place. Learning and practicing the conversation truly remains in the experience. And it doesn't produce a change and transformation of the experience that we are having. And what are we? What are we offering? What I offer is essentially to build a tribe here. In this case, I am speaking about women, but there are also groups of men. And to return to something very basic, anyone familiar with the concept of a village raising a child? In this sense, returning to community as a foundation for healing, the roles and anchors that are important to us in the group and in the community, they are essential for working with treatment providers and others. We see this today a lot in everything related to the recovery of those who are wounded and soldiers who arrive. The peer group goes through a shared process together. And the group is not something esoteric or secondary. It's not because there aren't enough resources. Rather, one of the most significant things within the process is shared healing. You can see that. It's also evident in the work of Peter Levine, who has written extensively on trauma and recovery from trauma. And this transition may seem like a semantic shift between illness and wellness. Because healing isn't just about symptoms decreasing. It's about well-being within our lives. And that's essentially the difference between being alone, lonely, and isolated within my experience. and the place of wow, of togetherness. Correct, accurate, and the word there in the title is not a mistake. The idea is our ability to sit and learn together. The group, the collective, does not perish based on suffering. It perishes based on commitment and a willingness to transform that experience and heal from pain. And the process does not remain within the boundaries of the group. We see its ripples in the experiences of the family and partners. We see its ripples in our ability to change culture, discourse, and norms. And the concept of healing is the ability to speak about sexuality in a different way. It reaches everyone, every space a healing person finds themselves in. And I took some of the key names that emerged from the testimonies of survivors. So, the first sentence and one of the first things that came up was the issue of dismantling the experience of shame. And the possibility of allowing vulnerability in the space. The first sentence is actually from someone who is still dealing with it. She is in the middle of the process, but that was her description. I am dealing with anxiety and fibromyalgia and pelvic floor pain. That's good. Let's not shy away from words. It hurts during sex. And that was one of the first things she assumed. It's the first time she can speak so openly, recovering otherwise. She spoke about my case and other cases in the group. I saw that pain during intercourse doesn't sit with a lot of shame. We don't talk about sex the way we talk about lunch. We don't talk about sex the way we talk about stomach aches. We don't talk about sex the way we talk about our knee in the group. The only place to talk about these things is not in front of a therapist in a closed room, but in an open room with women of different ages and different histories, just as we talk about pain in our hand. In 2 words, dismantling shame. How significant it is, and how much there is to it. That's part of the story of threat. And why? Why can it, on its own, reduce symptoms? Another thing that came up was the wisdom of the way. How does one person's experience within the group become learning for everyone? So, the advantage of a recovery group is to benefit from the group's wisdom. And not just from the wisdom and experience of my therapist. No matter how wise my therapist is with extensive clinical experience. It's still not a group of people who are together and going through a process. Group discussion, the discussion is airy. There are more diverse ideas and lines of thought, especially when we look at it as students rather than as a patient. I'll take you back for a moment to unpack some doubts. And someone who didn't even realize it says, wow, that's my doubt too. And that's also how I respond to pain. I too focus on the pain, or I fight it. And one description becomes something that others can also use to delve deeper. And to do much more thorough work in relation to the symptoms and their recovery process. The last sentence refers to that. All the insights of all the group members, from the learned knowledge, become the collective learning of everyone together. It doesn't remain that of each person separately. Simply amazing. It's really something they are seeing. And we, as a team as well. So, I took it, we talked about the syllabus, we talked about things that we are. That's how they learn them, and that's how I want it. A few points that are within this process. The first thing we start with is psychoeducation. First of all, knowledge and learning, as a basis for regulating and reducing fear of pain. Then we talk about change reactions, automatic reactions to pain. We identify the reactions and change them. From there we dismantle doubts. Developing emotional awareness, becoming familiar with each person's specific emotional threat mechanism. And truly building that map. A threat map and rebuilding a sense of capability. But not just physical capability, rather also emotional capability to cope with things, to face difficult things, and throughout our lives. So, if we summarize, I also want to summarize one by one the statements of one of the survivors here. Incidentally, a survivor who even became pregnant. She told us a few weeks ago about recovering from pain in relations. It's a life-changing thing. A change that touches deep. I've discovered this in my marriage, in my family, and almost in every aspect of my life. Like any revolutionary change, it is woven and shaped through learning. The fact that my group members also walked this challenging and questioning path. And this questioning gave me the strength and confidence to decide to walk it too. I too am now part of a group. A place to hold only those who are hurting. But mostly to learn how to do it together. And to change and heal. So, for me, this is truly significant. And it brings together something else, something more. It goes beyond individual processes. There is, within which we also offer an individual process. On campus, both individual and group processes are carried out. And at the clinic, we are also launching a process soon. So this is really wonderful news. Thank you very much for listening. And get well. A lot. So thank you, Yasmin. And we'll move on to our final and lovely speaker for today, Nitzan Bernstein. Nitzan is a social worker. She is an activist for women's health and invisible illnesses. She is a co-founder of the Endometriosis Israel Association. And she manages the alumni community of the Burity Incubator at the Bria Foundation. We requested her. Nitzan will speak about social activism and invisible illnesses. Nitzan is a role model for me. And I hope she will be one for you as well. After you hear her. Good. Thank you very much. It is a great honor to be the last speaker on such a rich and diverse day, and with so many amazing lecturers. And to the lecturers, thank you very much for the invitation to share the presentation. Do you see? You'll see soon. Yes, you see, thank you, excellent. So, today we will talk about activism by patients, and I've called it to give a title that is essentially how to turn the burning inner fire into something swift. And I think there's something really special and exceptional about it. And that is incorporating the concept of social activism as part of the treatment options. I can say that both as a patient and as a professional, I have accompanied women through such a process. And there's something amazing and no less healing in it. To heal from the pain itself, but rather to know that you can make a change in the world. And to be there for other women in the same situation. To grow and develop and change the world for women facing the same challenges. So, as Ahinoam said, I am a bud, I am a clinical activist and founder of Endometriosis Israel. A founding partner, former partner, and also work at the wonderful Karen Bryant Foundation, which was already mentioned today. I am speaking today about my journey. But I think it is a journey that parallels that of many activists for invisible illnesses, from different backgrounds and with different challenges. I think it can be like a sort of guiding light or compass. It could be helpful for other women who want to take part in something like this. Regarding existing activism, such as that of the Shlomo organization, which I will mention at the end, it opens up completely new avenues within this world of relationship pain and invisible illnesses, and perhaps even beyond. So, this first step is the spark. And for me, the spark is a fire that burns deep, deep within the stomach. It's not pleasant at all. It burns. It consumes. Or consumes. I don't know how to say it. I was actually diagnosed 14 years late. It happened after I suffered for many years from pain. The pain was very, very severe. They occurred as menstruation at the level of labor pains for a thin and small 13-year-old girl. She has to go through it every month. No one has a solution. It was pain related to relationships that began when I was sexually active. I didn't even bother to think there might be something wrong. I was so accustomed to living with pain. Therefore, I didn't think there was any help available to me. You are certainly likely familiar with the symptoms of endometriosis. I won't detail the rest, but I can say that when I came to my diagnosis at the age of 26, after 14 years I came shattered. I arrived in a state of very, very severe chronic pain. I began traveling the world trying to understand what this thing was that had befallen me. How does one pronounce a name unlike any other? Eindoma, see what it was. I needed to travel the world with an illness. On one hand, I was told it was common, and on the other, no one knows about it. My employers aren't necessarily convinced that I suffer to such an extent. People don't even know what it's about. And the feeling is one of an extraordinary sense of loneliness. And then you enter the medical system and encounter a very, very offensive and dismissive attitude. I've attached here a discharge letter from one of the very difficult hospitalizations I had for pain management. When I was asked if I had any underlying medical conditions, they simply wrote, generally healthy. Of course, I told them that I have endometriosis, but no one thought it appropriate to write that down. And in describing the patient, instead of writing, for example, in great pain, 10 on the pain scale, they only wrote crying non-stop. Essentially, the experience was one of utter helplessness, a constant struggle to receive rights and recognition, no matter where I turn. Whether it's a university, social security, cannabis, workplaces, it doesn't matter what I've done. I truly felt sorry for the cliché of transparent isolation, and it was very, very significant. Above all, the feeling that it was just me. That it was just me leaving doctors' offices crying. That it was just me no matter what I do. I can't find any improvement. It's just me wandering around the world with fire in my belly. And no one sees it. And most people don't even believe it. And here I come to the other side. On the community side, I actually do not agree with my predecessor regarding the fact. A community keeps people in the same place. I experienced a community. And I also tried to manage a community in a way that the community could help you grow. And when I arrived at the community, at that time we were 300 women in the endometriosis Israel community on Facebook. I found a home. I found a place where I am finally understood. A place where I am finally not the only one in the world dealing with this unbearable and indescribable thing. And suddenly I wasn't just that. Not one job but jobs. It wasn't invisible. It was invisibility, incomprehension, and it's true. One can stay there. This place is only of difficulty and pain, I believe. From my experience, I see that most communities actually grow a few steps forward. And within this community, I have found so much more over time. After a year, I became the community manager. Even before that, I began both implementing things within the community and receiving so much from the community, incredible qualities. First and foremost, knowledge. Vast knowledge that wasn't available anywhere else. The entire internet was full of nonsense. There was nowhere to get knowledge from the field. There was nowhere to talk with other patients. Humor, resilience, courage, growth, a call to action. The things that came up, the anger, that fire that brought an opinion or a burning within me. It was actually a collective fire. And when there is a burning collective, it's not necessarily bad. It can be channeled and turned into action and creation. And I felt that the spark of my activist journey was this community. The place where I realized I was a part of some social problem much larger than myself. There are many women like me. Together, we are a considerable force that can make a change in the world. And from that came essentially the third step. The third step is the step of creation. It began also from my very, very personal need for survival as someone who could no longer work because of so much pain. She wanted to continue to feel significant. I had just finished a degree in social work. I said to myself, what am I going to do? How can I continue to feel significant when sometimes I can't even get out of bed? It happens after trying everything. I had already been through one surgery and so on and so on. And essentially, I started to see what things were surfacing. And also to address them. And also to consolidate them into pools of knowledge, or knowledge aggregation. So, at this stage we had our first community project. It was with the Indo-Israel Sisterhood Group. The project was a big sister journey. Took place exactly 10 years ago. I wasn't a manager yet. Even then, I already felt that this community had something special. Could offer advice. A mentoring project for veteran patients who accompany newly diagnosed patients throughout the entire process. The process was very, very unsettling and frightening. Later, this project evolved into a nonprofit organization. And to this day, it continues in different forms. And it's very, very moving. The second thing I did was build a website. This is the first information of its kind in Israel built by a patient. It was the largest in Hebrew at the time. Call me. I did this 10 years ago as well. Because I read so many stories in the group. And I gathered so much knowledge from there. And I didn't see it written anywhere else. There were some texts, of course, not everyone is comfortable reading in English. And the goal was actually to make the knowledge accessible. For the treating doctors, the treatments and the rights. The different ways we can also thrive with this illness and not just survive. The third item was the first awareness post I wrote on Facebook. Over a year or two. I didn't even dare to say that I have endometriosis anywhere. I wrote a post out of the blue and it got 700 likes. Back then that was crazy. Suddenly I said to myself, it seems like there's a presence and visibility given to the matter. It's also transparent. Women tell me they identify with it, that I've given words to their incomprehensible experience. What an amazing thing. And I think it began this way. I started to feel the sparks of myself, not just burning from within but shining. It shines within me. It heals me from within, and it's also beginning to spread its light outwards. And from this place of post, and the understanding of how much needs to be said about endometriosis, and what a thirst there is for endometriosis in the public sphere. This thing that no one knows the name of, and no one dares to talk about it. And it relates to the uterine lining and all sorts of terms that are unpleasant to say. So I embarked on my journey to a section called Visibility, which essentially involved being interviewed in various places. It was a certain momentum of listening as well. And various parallel organizations began to address this. And there was a great deal of desire and also requests to me. That is to say, I didn't necessarily initiate it. But I began in essence to go out and engage. Really to dare with videos here. With an article in Elle, we did a campaign about the years of delayed diagnosis. The goal was first and foremost for people to know who we are. To know that this exists. And to have a very, very significant reduction in shame regarding this disease. For years, no one dared to speak about it. This place we have progressed to a section. I think it is the most significant and the most moving. That is actually the fifth step. It is partnership. We created the Endometriosis Israel Embassy Project, and I am Michael Amit and Iris Pink. We submitted it to the Burrout Innovation Hub and the Healthy Nation Fund. We were in the first cycle, and essentially we trained 15 women with endometriosis. We want them to be activists and thought leaders in their communities, return to their communities, and become activists, and essentially the foundation and basis of what comes later, which is the Endometriosis Israel Association, the association that arose together with Aya Wertheimer, a partner. Aya studied social work with me, and she diagnosed herself thanks to my website. So you can see these ripples of change growing and expanding. She said to me, let's establish an association. I said to her, okay. And so we embarked on a completely crazy journey, with additional partners who came from the training program of the Endometriosis Embassy. I've placed here the picture with Dr. Ori Dior, who is wonderful, and Dr. Tali Sahar. It's a bit late, but this was a truly groundbreaking conference that we held. The conference was the first Orthodox endometriosis conference probably in the world. But I've included this picture. The endometriosis clinic at Hadassah was one of the clinics with the most partners we've experienced. This happened when Ori Dior returned to Israel from Australia. He contacted me. He sat with me and asked what patients need. I think there's something amazing about that, and it's the goal of every patient organization. Ultimately, it's about working in partnership with the medical system and influencing it from within. And that's how we arrived at the sixth aspect, which is healing. This is my own healing. And it is our healing as one community of each other. And the very fundamental failures we encountered along the way. Everything was a struggle. But much of that struggle ultimately led to extraordinary successes. We ran a campaign for recognition. It turns out you need to run a campaign for endometriosis to be recognized as a chronic disease by the Ministry of Health. Just wasn't obvious. So we needed to convince them. And there was a whole campaign. And it succeeded. We created the first dedicated form for the disease. Any disease with the National Insurance Institute. So it's a form that, instead of you collecting many documents and bringing them before someone who doesn't know what endometriosis is, you will fill this out with your treating physician. We provided training for National Insurance Institute doctors. The training dealt with endometriosis. It also dealt with rehabilitation clerks regarding these matters. We accomplished a great deal of this thanks to them. Here are examples of campaigns we undertook thanks to the community. The community is what led this effort. Community power was also very strong on Facebook at the time. It was community power that created these incredible ripples in digital campaigns, and media visibility, and so many other things. And essentially it continued. Our way of engaging in countless truly amazing areas. If it's making knowledge accessible, I just put the live broadcast we did with Ahinoam Levseji here. She volunteered to do a live broadcast with us for our patients. We've been doing this for years. We've brought in dozens of lectures from top experts. We've held large conferences. It was based on the largest endo survey, which included 2,000 patients. You can see some of the data we collected below. And that's how we proved the things we felt throughout the entire process. The feeling of lack of transparency, dismissiveness, and a lack of understanding from the system. These weren't our amorphous, hysterical feelings. And here are the data. With them, we can proceed and continue to change policies in other locations. We have gained another Minister of Health dedicated to rights within the Ministry of Health. And that always deeply moves me. This image is because of an organization or a disease that had to fight for it even to be recognized as a chronic illness. Or for someone to think it's worth discussing. They put our picture on the Ministry of Health's page. It felt like a pivotal moment in our lives. I think there's also a picture of me here from a lecture that was one of the most important I've ever given. It was at the endometriosis conference at Hadassah, which organized lodging. There I spoke about the film, the things endometriosis patients need from their doctors. I said things that were very difficult to talk about at the time. About trauma-informed care. About power dynamics in the treatment room. About sexual vulnerability in front of them. I was the only speaker, addressing a completely medical audience. She was not a doctor. This is healing for me. This is where we reclaim our power and influence it outwards, and find within it strength and the ability to impact others. And what about us? We're also talking about the nervous system and releasing it from fight or flight. I think some of the best ways to do this are through activism. You reclaim your control. You reclaim your voice. And you know you have something to do. And you are not alone and helpless. Within this campaign and within all these steps, we received a great deal of inspiration and solidarity from other organizations. These organizations were in the field. We were always in collaboration, of course, with Karen Bria as well, but also with organizations representing patients more specifically, like MS0, and also my community, Parmesan, the Fibro community, a community of Lake El Arzadanlos, and the community of Shlomo. I think there is a great deal of mutual enrichment, a great deal. That's how learning from one another happens. Friendships are formed and truly partnerships that I think are very exciting. And there is a lot of similarity between the things. So to wrap up and move on from the topic of other patient organizations, I also want to tell you that there's a very, very important webinar that Shlomit's organization is holding. I'm including the webinar as part of my activities at the Healthy Fund. Shlomit's organization was accepted into Phase B of the Innovation Incubator, and they decided to create a webinar specifically for primary care. It focuses on immediate tools for identifying and treating vulvar pain. Dr. Einav Bahar and Dr. Michael Bronstein are featured there. They are leading women in their field. The goal is to make it as easy, quick, and simple as possible for people in primary care to identify pain in the vulva and vagina, and to refer patients onward for specialized treatment. There is a barcode here to register. I am very, very excited about this initiative, and I think it is truly so vital and important, and I really hope there are hundreds of people registered. That is all, so thank you very much for listening. It's really, really nice to close out this day. And thank you Ahinoam and Michael for the organization. Thank you. Thank you very much. So there are a few questions. Wait. Okay. So, someone is asking if you can answer whether she has had 6 treatments with a physical therapist. Pelvic floor is good. What do you recommend for her? So the question is whether there has been any improvement. And then it is possible to improve further. And if there is no improvement, then it's necessary to go back. Or, if you have had a diagnosis from a doctor, then go back and see if there are any other tools that can be incorporated, and if so. If not, it is clear that you should go for a diagnosis from the doctor, and to see that we haven't missed anything. And sometimes when we see that something in the body is not progressing, regarding marital stress that needs to be addressed. So even then, check other areas as well, if there is no improvement. And if there is, sometimes patience is needed and you need to continue on your path. There is another question in the same family of questions. Someone says she has been diagnosed with Ginsberg physiotherapy for 5 years. However, pain remains deep within the patient. Even with psychological and couples therapy, and with all the help she has received, what else can be done? So, I will answer that if it is all right with you. It brings me back to the first lecture where I ask not what the treatment is but why there is still pain. Why is there pain deep down? Perhaps adhesions, perhaps endometriosis? It's a little difficult for me to answer something like that. I don't know the medical background after all. I suggest returning for a checkup. And to see what causes the pain and then try to continue from there. Is there a question for Yasmin perhaps? But before that, I must say I need to finish the day with Nitsan. It was brilliant. It wasn't planned that way, But not after all the things one hears, and in the end hope, strength through action, healing. It's truly moving and joyful. I'm glad this is the taste that will remain at the end of everyone's last bite. The table is full of dishes from today. There's Yasmin with a question. Is this group for you, I suppose? Who else was shown this to? Someone who doesn't know. They showed a CD. It's about obsessive thoughts in a relationship. Or the relationship CD. Is this the right person? Do I love him enough? And it's like obsessive thoughts about the quality of the relationship and about the relationship itself. Written here is a nosoplastic perspective. The truth is, the letters are here. They've been swirling around with a foreign word in the middle of a sentence. But the question is this group also suitable for those trying to heal from something other than nosoplastic pain? So I'll say it this way, there are definitely groups. But you really need to see if it's a good fit. For example, at the clinic, we are opening a group specifically designed to deal with pain during sexual relations. Sometimes, even in the initial process, we can see who is a good match for whom and why. And who needs additional individual treatment. It is possible that there will be both a group process and an individual process. I'll give you an example. At Campus Mirav, there are individual processes alongside a group process. These build a tailored solution for everyone, for each person facing pain. So it's very connected. It's as if we are really trying to adapt so that there are good and effective recovery processes to provide the necessary support and the professionals a person needs within the process. Is there a question about whether the Vardok rehabilitating clinics are recognized by national insurance? To the best of my knowledge, no. Anything else? Another question about the group. Is the group also suitable for those trying to heal very difficult things outside of that pain? Nosoplastic? That will happen anyway. We've already addressed that, okay? And I think that's it for now. Something down there. How can I register for the group? Yasmin, are you? Do you want to respond and add something after this? Phone or website or? Can I simply look up the details? Write Yasmin Boas. You'll find the contact information and be able to send a message. I will also send a link to the website here. Okay. Ask what the connection is between polycystic ovaries and pain during sexual intercourse. There is no clear connection. Unless there are some hormonal changes that cause atrophy. This doesn't usually happen with polycystic ovaries. And how can I know if I am progressing correctly towards full healing? How can I know if it's simply a matter of patience with a long process, even a very long one, with one treatment? Or is it time to try a new approach to treatment? Sharon, it seems like this is a question for you. I don't hear you, please speak up. You're being quiet again, I missed you. How can I know that I am on the right track for full healing? How can I know if I simply need patience for a long process? Even so, perhaps it's time to try a new treatment approach. Wow, that's an excellent question. Okay, I'll put it this way. Experience makes the interest feasible. I always tell our patients, our excellent therapists, you've come a long way. And you are motivated to solve the problem and to receive good care. We will connect you. But you alone know how you feel in the room. Sometimes there's simply no chemistry between people. So if you are in therapy, and you can share, and you feel that it meets your needs, but if you feel that the atmosphere in the room isn't really allowing you to be vulnerable and to reach depth, and to put things on the table, that doesn't mean she isn't a good therapist. And that doesn't mean you aren't okay. Sometimes you really might need to switch to someone who is a better fit. Patients don't feel comfortable with you. They feel embarrassed, so they try hard and attempt to compensate. And often it's about how I am. How will I know that things will be better than this? I don't want to be exposed again. I often recommend going to a place that offers a wider range of experiences, and to get a really good recommendation from someone. No one can guarantee to anyone how they will feel okay. But it's very important to listen to your body. Do you know if this treatment is satisfying you? Because there's a technical question here. No, they are not. They are not physically available through health maintenance organizations. They are also not covered by the healthcare basket. Only private insurance covers them. There is a question here, when to give up? The answer is never. Yes, I think it could be done with a choir singing in harmony. Don't you? No, don't give up. But sometimes it's possible to rest a little, sometimes. People set out on a journey. It requires a lot. Strength. And sometimes it's perfectly all right to sit a little by the side of the road and say, just need a little time, and then, to do another stretch. Because unfortunately, in some cases there's no swing, and sometimes it truly requires patience. It also costs money. I'll say that there was another question that I don't see now. But someone asked where to turn for help. There are so many therapists and it's confusing. So I think it's terribly important. As if there's a list also in B. On the website of the Israeli Association for Sexual Therapy, there's a list of all the certified therapists and certified therapists in Shlomo. There's a list of many recommended physical therapists. It's really important to know where to go. And that there are people who are experts in the field, because there are quite a few charlatans in these areas as well. At least in the field of therapists, because there is no law regulating sexual therapy, and no law regulating psychotherapy, people just do it. They take short courses and call themselves all sorts of bombastic names, and they are not professionals. It is very important to turn to professionals. Okay, so the question was asked again. Where can you also get the recording? A link should be sent. But we will also upload the recordings to our website, Hadassah Medical Center. So I think we can move on to the summary. If we have anything else to say, then first of all, I wanted to say thank you very much, both to Michael and to Sharon for this shared journey. I think I learned a great deal from it. You two were truly wonderful partners. Amazing. So thank you. And I really enjoyed today as well, and I learned new things. And we will need to think about what we will do next year and what we will do until next year arrives. Several ideas have already come up. We are left with many plans. Also, to say something in conclusion, I wrote it here. I wrote it as you did. You said, "Wow, how many things I learned today." One thing is how much. This topic is interesting. The second thing is how many super professional professionals exist in the country. They work in the field of pain related to sexual relations. Simply amazing. We have a global resource. This is a place where we really need to give them more and more exposure, so that people can reach the right place. And that thing, the third. I've been lecturing on this topic for several years. Men are not simple. And today I learned that men are transparent. There isn't even a distinction in the DSM regarding pain in men. There's another way. There's so much more to do. And all of this I learned in just 10 hours. It was truly amazing. Thank you, thank you. Michael, we are waiting to hear from you. What can we say? It was pure pleasure. The whole journey, from the moment the idea was born and all the arrangements, everything. All the collaborative work with everyone who participated in the steering committee. We sat together several times, all the lecturers who were invited. I think it was evident even to those in the audience that we had fun and meaningful work together. And we also thank the audience and the feedback we received. Your comments were helpful, and this is only the beginning. This is what I wanted to say. This is only the beginning. We have been working in this field for years. And we see the new generations of professionals. They are taking up the banner and moving forward. And we have done a little, and there is still so much more to do. And it's so much fun. I want to mention that there is an art exhibition on pain in relationships. It's at a factory, which is a super cool place in Jerusalem, and it's art. You should go see the exhibition on pain in relationships. Look and be moved. We will be there next week on Thursday. And we hope it begins to resonate. I am waiting for the first film regarding other media. The film is about the first narrative film. I'll respond with a video on Bridge, perhaps, I don't know. So, which episode of Bridge won't be a spin-off, I'm sure. Someone who really experiences pain during sexual relations, just one. About 5, so thank you very much to all of you. Also, to Hadassah Nurit Meshulam, Hadassah from marketing, who helped us, supported us, it's not taken for granted. And to the technical person who supported this entire event. You're welcome. Yes. Definitely not. So thank you very much and good night to everyone. See you next year. Thank you. Bye.